Good morning, dear participants of our first Belarusian, Lithuanian, Polish online otorhinolaryngology Congress. We're happy to meet you online. And of course, first of all, we want to give the floor, of course, to the head of our university, dear Elena Kratkova.
Good morning. I'm glad to welcome the participants of the conference. Thank you all for your active registration. I wish you productive reports and discussions. I hope this time will be useful and interesting. Good luck. Thank you.
Thank you a lot. And we continue. Now we are happy to give the floor to the organizers of current Congress, dear Oleg Khorov, dear Kazimierz Niemczyk, and dear Virgilius Uloza. Please.
Thank you, dear Rector, dear colleagues, and dear friends. On behalf of the organizer, we invite you to participate in first International Congress of Otorhinolaryngologists online, the first Belarusian, Lithuanian, Polish online Congress Otorhinolaryngologists. As part of the Congress, we will discuss the most actual problems of otorhinolaryngology. We will evaluate the experience of colleagues and try to find new opportunities to improve the quality of treatment for patients with ear, throat, and nose diseases. We believe that this event will allow you to gain new knowledge, new friends, and will be held in a pleasant, friendly atmosphere. We will make every effort to adapt the information program and discussions to the virtual opportunities so that you can participate in the event as fully as possible. During the Congress, you will be able to ask questions in the chat and the answers will be given the invite experts. You will be able to visit virtual poster stands. We hope that despite the current difficult situation, this coronavirus infection, we will soon be able to meet and exchange experiences face to face. Good luck.
Thank you a lot. Thank you a lot. And now we are giving the floor to the dear Kazimierz Niemczyk from Poland. Please.
Dzień dobry. Good morning. It's my pleasure to meet you, colleagues from Belarus, colleagues from Lithuania, and especially my personal friends, Virgilius Uloza and Oleg Khorov. This is a continuation of our bilateral Polish-Lithuanian Congress, which we name those meetings as polite meeting. So I hope that this continuation is also which fulfill the term of polite meeting Congress, and I am persuaded that the program we prepare is very interesting for all colleagues, and it's the only problem that we cannot be together in place in Grodno, but I hope that next time it will be possible to meet and organize get-together meeting during and after Congress. So once more, I would like to thank Oleg for all efforts to put on this Congress, and I think that there is a good continuation of our Polish-Lithuanian ENT traditional meetings. Thank you once more.
Thank you a lot. Thank you. And now we're happy to give the floor to dear Virgilijus Loza from Lithuania. Please.
Yeah, thank you very much. Good morning for everybody. It's my great pleasure and honor to be part of this opening ceremony and of course part of this Congress. As every event, everything has some background and some history. So please let me go to our history. Could you please put these slides back from the first one? Yeah. Yes. So everything started several years ago. It was the first Lithuanian-Polish ENT and skull-base surgery Congress, as we call it at the time. So next slide, please. And it was in 2008. And here you see Professor Nemchik and me, who we are the organizers of this event. Next, please. Here are the participants in Druskininkai. Next, please. Then 2 years after, the second Congress, Lithuanian-Polish ENT Congress, as we call it, was held again in Druskininkai. You see more participants every time, increasing numbers. Then in 2013, the third, and the motto of the Congress was proposed by Professor Nemchik. We are ready to have a good scientific and social fun, and it was. You can see scientific part of the Congress. Next, please. And of course, social with slides and joy. Next, please. Then 2015, the third Congress in August of the organizers, the main organizers, the fun. Next, please. 2017, the fourth Congress again in August of the same motto. We are ready to have a good scientific and social fun, and we did it. Next, please. Scientific and social. And finally, 2019, Druskininkai, the fifth Congress in Druskininkai. Well, the same faces again. Next, please. So the scientific part and social also. And participants not only from two countries, but also international participation and the same motto. We had 184 participants, 35 exhibitors, 4 international courses, 79 oral presentations, and 12 posters. So now is the time for the today's and tomorrow Congress, the first International Berlation Lithuanian-Polish Congress, otorhinolaryngology Congress. Of course, unfortunately, it's online, but nevertheless, I hope we will have a great scientific fun and also fun for our indirect online communication. So I wish very great success for all of us and of course for the Congress, and thank you very much to the organizers. Thank you.
Thank you so much. Thank you for wonderful photos. I think everybody was happy to remember those times. And now first of all, we want to remind you the time allotted for each report is 20 minutes. 17 minutes is for the report itself, and 3 minutes for the questions. Dear reporters, we also kindly ask you to comply with the time limit. Also, we want to remind you that once every report is on air, all the rest supposed to turn off their microphones, so it will not cause any problems with their audio. Also, we want to remind you that there is a live translation on YouTube. We have two YouTube channels, one with the English language and the other is with the Russian language. So please be free to ask any questions you like using their YouTube channel, YouTube chat, and using their Google Meet chat also. And now we begin the section number 1. It's called Current Aspects of Clinical Rhinology. The moderators of this section are Oleg Horov from Belarus, Tomasz Gottlieb from Poland, and Saulius Vaitkus from Lithuania. So, and first of all, we want to give the floor to the first reporter, Yeremenko Julia from Belarus.
Hello, everybody. Do you hear me? Hello. Do you hear me?
Hello, Julia. Yes, we can hear you well. So
Okay.
please,
Okay, thank you. Thank you. I will begin in some second. Okay. So, hello, dear colleagues. I would like to introduce you the results of our research, and now we will speak about acute rhinosinusitis and biofilms. Acute rhinosinusitis, according to the European position paper on rhinosinusitis and nasal polyps of 2020, is defined as, in adults, sudden onset of 2 or more symptoms, one of which should be either nasal blockage or obstruction and congestion, or nasal discharge due to anterior or posterior nasal drip. And it may be and may not to be facial pain or loss of smell. Pediatric acute rhinosinusitis is characterized by the same symptoms with one more symptom. This is a cough, principally at night time. All symptoms have a duration less than 12 weeks, with symptom-free intervals if the problem is recurrent, with validation by phone or interview. Viral rhinosinusitis, we can name it the common cold or an acute rhinitis, is induced by respiratory viruses. Rhinoviruses and coronaviruses are the most common viruses isolated from adult acute rhinosinusitis. Less often we can meet influenza and parainfluenza virus and other. All acute rhinosinusitis or the common cold or an acute rhinitis is induced by respiratory viruses. Rhinovirus can be divided into viral rhinosinusitis with a duration of symptoms less than 10 days. When symptoms increase after 5 days or when symptoms are persistent for more than 10 days with less than 10 weeks duration, then EPOS classifies this acute post-viral rhinosinusitis, and only a minority of acute rhinosinusitis is from bacteria origin. It has been placed at half to 2% of all viral infections, and its development to assume as a complication of post-viral acute rhinosinusitis. Acute bacterial rhinosinusitis is defined by EPOS by at least 3 symptoms of the 5 below: discolored mucus, severe local pain, often unilateral, fever more than 38 degrees, raised erythrocyte sedimentation rate, and C-reactive protein, and phenomenon of double sickness, if it happens, worsen again, initial improvement. Nothing changed since EPOS 2012, and according to last research, acute bacterial rhinosinusitis is induced by 3 main bacteria. So these are Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. And we don't forget about biofilms. According to last researchers, the main biofilms formative bacteria is Staphylococcus aureus. And let's remember, what is the biofilm? This is an aggregate of microorganisms that are embedded in a self-produced mucopolysaccharide matrix. This matrix protects bacteria against external adverse factors, including antibiotics. Biofilms is an ideal environment for exchange or genetic information between bacteria. Accelerated horizontal gain transfer, including antibiotics resistance, is carried out in it. Surviving after antibiotic therapy cells, the cell groups persisters, get a resistance to external factors. All this leads to chronization of the infection process, unsatisfactory results of standard antibiotic therapy, and protracted illness. And it obviously that if you're able to foresee that we deal with biofilms-induced disease, we shall prescribe appropriate treatment. For example, antibiofilms, antibiotics from the first days of illness. But we have the problem, how to recognize biofilm-induced disease. And now about our research. It included 57 patients with acute bacterial rhinosinusitis confirmed by the declared criteria. All patients underwent a bacteriological research of maxillary sinus content and determination bacteria's ability to biofilm formation. The second step was a comparative research of anamnestic, clinical, and laboratory data of with and without biofilms patients with identification of distinctive features. And our results. The ability to biofilm formation was discovered in 35 patients. It was 67%. 34% of bacteria had the high biofilm formation ability, 46% moderate biofilm formation ability, and 20% had a low ability. On the next step, we dealt only with patients with high and moderate biofilm formation ability. Our comparative study of with and without biofilms patient data identified the following biofilm forming microflora clinical predictors. These are the disease duration more than 14 days, smoking, raised erythrocyte sedimentation rate, leukocyte intoxication index is more than 1.5, raised eosinophils, C-reactive protein, and surgical intervention on the nasal septum turbinates over ear. Each predictor's significance was statistically determined by logit regression. And we got the next. The disease duration more than 40 days got 3 scores. Smoking got 2 scores. Raised erythrocyte sedimentation rate level in the general blood test got 3 scores. Raised C-reactive protein more than 10 milligrams in the biochemical blood test got 2 scores. Surgical intervention got 1 score. Raised eosinophils more than 5% in the general blood test got 1 score. And leukocyte intoxication index is more than 1.5 got 1 score. The result evaluation was the next. All scores were summed up, and when our patient got less than 4 scores, we considered that our patient have a low probability of biofilms caused disease existence. When our patient got from 4 to 8 scores, they have a moderate probability of biofilms caused disease existence, and more than 4 scores, they had a high probability of biofilms caused disease existence. Thank you for your attention.
Thank you a lot for your great presentation. As far as we can see, we did not receive any questions, so everything was clear, we think, for all the listeners. Thank you one more time. And now we are giving the floor to dear Tomasz Gottlieb from Poland. And the name of his report is Endoscopic Resection of Sinonasal Tract Neoplasms. Thank you. Please.
Yes, could you please close the presentation of previous reporter because we cannot load our presentation? Thank you very much.
Yeah, we closed the presentation. Они сами. Okay, we see your presentation very well. Thank you.
Thank you very much.
Okay, so let's start. So I decided to change the topic a bit and just to focus on the endoscopic transnasal management of sinonasal malignancies instead of all of the tumors. And we'll just briefly summarize our experience and give some overview. Basically, we can remove this tumor using microscopic surgery, external surgical approaches, or endoscopic sinus surgery, and of course, regarding it depends what are the experiences of the surgeons, but of course these methods can be combined. So what we are talking about is it can be a biopsy just before we start the treatment, total resection of the tumor, or we can perform some kind of extended biopsy or gross total resection. And this is the example of the patient who was recently hospitalized in our institution, and due to COVID infection, you can see that the tumor is quite huge. So what we did, we performed excisional biopsy, and the end result was that this was SNAC, so sinonasal undifferentiated carcinoma. This was not a mistake because the patient was irradiated, and of course, if we performed biopsy, then perhaps we could irradiate her before and then do something with the remnants, but it's not a mistake. However, in case of this type of tumors, like NK nasal type lymphoma, this could have been mistake. So we have to be very cautious when starting surgery, and of course biopsy is preferred. However, sometimes in cases like this, we perform gross total resection, and of course it depends on how comfortable you feel about your experience and the abilities of safe dissection, because as you can see, there is some orbital involvement, but happily there was nothing serious, and we could remove it safely. So we are speaking, of course, about malignant neoplasms and some locally aggressive neoplasms. When you start this type of surgery, you start with sinonasal, only this neoplasm that are confined to sinuses. And first, it's better to, of course, to start with benign of locally aggressive tumors, and then with experience, we go higher to the skull base and to the tumors that I will show as last ones. Then histopathology. Of course, we have good and bad players, and you know that squamous cell carcinoma, adenocarcinoma, and low Hyams grade esthesioneuroblastoma. These are these good players. The same about lymphoma, because we know that the overall survival is quite high in these patients. In contrast, these tumors like sinonasal undifferentiated carcinoma, sinonasal endocrine tumors, malignant melanoma, or high-grade, Hyams grade esthesioneuroblastoma, these are these ugly tumors. So we know that overall survival is, of course, much lower. And just like in malignant melanoma, we have quite high percentage of patients with local or distant metastases, which of course lowers the overall survival rate, 5-year survival rate. So, and basically we can divide this tumor in these types. This is one of this type of divisions. Our experience between 2010 and to 2012 to 20 is 39 patients. I will not get into details because anyway, although it may seem that there is quite a lot of these patients, when you look at histopathology, that this is quite diverse group. So driving any conclusions from this type of diverse group is really very difficult. So I will just briefly summarize what we did and what our experiences. And well, our first experiences, we described it in 2014. And these were just 10 patients. And basically the main principle and the main feature of the tumor, which is quite important in terms of possibility of endoscopic resection, is how the tumor is attached to the surrounding tissues. Because as you can see here, this is quite huge tumor in an old lady, which appears to be squamous cell carcinoma, and this huge mass was pedicled on quite small pedicled. It was in the upper posterior part of the nasal septum, and this is after resection. This is post-op, just like 3 months, and the lady is okay. She's still alive after 6 years. In contrast, this type of tumor, like this one, it has broad attachment, and unfortunately this attachment is to the lamina papricia, so we have to be very cautious about what is the extent of invasion. If this is only just the bone of the lamina papricia, or this is periosteum, or the tumor gets into the intra-orbital structures like the muscles, the fat, and so on. So MRI is the best option to check out what are we dealing with, because if there is extensive involvement of the orbit, then of course we have to rather switch to external approach. So this is pre-op, this is post-op, and this is one of the quite recent cases, which was not very advanced, as you can see, and with drug-free procedure and then the proton beam therapy, the patient is quite satisfied, and of course we too. There's 5 years after adenocarcinoma. The way how we treat it is quite similar. We have to be, of course, aware of the fact that this can be multifocal tumor. We have to follow these patients very closely for many years, because there can be some new foci of this tumor. But basically, the way how we treat them is surgery and then irradiation. So then this ugly player, which is malignant melanoma, was one of the first cases that we had, and we were very happy with the result. As you can see, this is quite huge tumor attached to the olfactory groove. So this is post-op result. This is how it looked like during the, well, I cannot start the film. Okay, so this is the olfactory groove, and you can see that the dura is already exposed up there. There is frontal sinus, and so you can see this is the end result of the surgery, and this small CSF leak here was covered with the flap taken from middle turbinate from the opposite side. Just now we are drilling the bone, and then there will be some small CSF leak, and so let's go. This is post-op, and unfortunately in 2017 there was a relapse of the tumor, so you can see that the frontal sinus is opacified. We tried biological treatment because this is some alternative for these patients currently, but unfortunately the patient dies. So this is totally unpredictable tumor. Even if you perform quite good surgery, you cannot never be sure what the end result will be. So this is the case of leiomyosarcoma. So there are many rare tumors that we are dealing with. The most problem with these rare tumors is that histopathology result is very often delayed. So in some cases there was like 3 months delay because histopathologists, they were not sure what type of tumor it was. And this is quite important in terms of radiotherapy that should be started rather earlier than 3 months before. Another examples, this is SNAC, which is quite aggressive tumor, and we know that in most of, especially advanced cases, we should start with radiotherapy or radiochemotherapy, and then the remnant should be resected. As you can see here, the posterior wall of the maxillary sinus is invaded, and so this is the movie from the surgery. This is posterior wall, this is the tumor, and step by step we are removing, exposing the muscle, temporalis muscle, and this is at the end of the procedure. And what we can see here is, as you can see, quite a good lesson of anatomy. So this inferior orbital fissure, V2, sphenoid sinus, median nerve, and infratemporal fossa. And lastly, esthesioneuroblastoma, which is the most difficult to treat, and the experience that you must have to deal with this type of patients is especially with these ones that invades the cranium. This is the most difficult thing to do. And well, we had 4 cases. This is quite interesting case with SEADH, syndrome of inappropriate ADH secretion, and the patient was cured, and endocrinologically she's fine. Another case, this was surgically treated, and we took biopsy from the dura. It was cleared, and the patient was irradiated. This is post-op result. And then currently we had some, 2 of these esthesioneuroblastomas that invaded the brain. This is how it looked like before the procedure, and this is a video from the procedure. And this is at the stage when all the sinuses are open. This is the sphenoid sinus back there. This is the tumor itself that we are just removing the part from cribriform plates. Then the draft free is being done, and then there is some mucus that will be relieved from the left frontal sinus, as you can see. So gradually we are exposing the skull base, then identifying anterior ethmoidal arteries, and then we make a circumferential removal of the bone around the tumor, and then this is right anterior ethmoidal artery, and then we'll expose the dura, and so this is the frontal sinus. This is the tumor in the center. This is how we remove the bone around. So you can see the pulsation of the dura. If I exceed the time, please just stop me, okay? Because perhaps this presentation is a bit too long. Okay, and then we are removing the bone around, exposing the dura. So this was the place where the anterior ethmoidal artery on the left side was coagulated before, and then we expose more and more of the dura, and gradually we are gaining control, exposing more and more. And the most important thing is to find the right the right spot to enter the dura. So just now the remnants of the bone covering the tumor is being removed. Sorry for poor quality, but okay. And well, perhaps it's a bit too long, so we can advance it. Okay, so now the dura is exposed, and then after we coagulated the dura around, we are cutting the dura, and the tumor will be, the intracranial portion of the tumor will be exposed. So we do the same like with the bone. We must remove this dura, and then you can nicely see the tumor. And then we are gradually dissecting the tumor from the bone, from the brain. And well, my neurosurgeon, my colleague neurosurgeon helped me with this, but they basically, as you can see, this is four hands surgery. And then after we remove the tumor from the olfactory bulb, well, first the falx, which is the quite important part of the dissection, because if you make an injury to sagittal sinus, then there can be profound bleeding, and so step by step we are exposing the brain and dissecting the tumor from using coagulation. So now the tumor is removed, and now the most difficult part, which is skull-base reconstruction. We used temporalis muscle, and well, of course, it was multi-layer technique. So first layer was the muscle, free flap, and then it was covered with different. So this is first surgical on the surface of the brain. Then this is the flap from temporalis muscle, and then it was covered by duragan and other artificial materials. So this is tahosil. Duragan, Surgicel, and then this was the flap, and this is pre-op, this is post-op, and the patient underwent irradiation, and it was quite successful. In contrast, the next patient that we did well, and the intracranial involvement was less in this patient. Unfortunately, he underwent proton beam therapy, which was quite aggressive, and currently he must have been admitted to our department because there was huge necrosis of the flap, and there was pneumocephalus, and we had to reoperate him. So now we are fighting for him. So to summarize, the indications are evolving, and currently involvement of the dura intracranial involvement, pterygopalatine on infratemporal fossa involvement on frontal sinus, limited involvement on the frontal sinus, or involvement of nasolacrimal duct. Of course, limited is no longer treated as a contraindication to surgery. Thank you. Sorry if I spoke too long. Thank you very much.
Thank you so much for your presentation. It was a great presentation. I'm sure everybody was impressed by it and by the results. And we received a couple questions for you. If you don't mind, we will ask you them. Okay?
Okay.
So the first question was, do you perform any sort of plastic surgery afterwards? And if yes, what is the time period you wait before any plastic reconstruction of the surgical area? Thank you.
Okay, so it's quite rare to have such a need, because if you performed the surgery endoscopically, as I showed you, then you know all the structure of the face are intact. We had, of course, one exception. I used shaver in a patient who had lacrimal sac involvement, and unfortunately I penetrated to the skin. And so she has some kind of fistula between the nose and the skin of the face, in the area of the lacrimal sac, which was removed. And the problem with her was that she underwent radiotherapy. So this tissue is locally quite weak, and we decided to wait more than 5 years just to ensure that our follow-up is not compromised, and by local flap which can cover the site of recurrency. You know what I mean? That we do some reconstruction, and then you have a problem. Is it relapse or not? So it's better to wait, in my opinion, because this first, after irradiation, these tissues are not like healthy ones. This is the first argument, and the second one is that we have to be sure that oncologically everything is okay, and there is not going to be recurrency beyond under the reconstruction that we performed. But with this type of, as you could see, with this type of surgery, it's quite rare to perform any reconstruction, because if you remove the eyeball, then this is open surgery. So this is not what I was talking about. Okay. Any other questions?
Thank you so much for the answer. Yeah, and one more question. What is the maximum age of patients that undergo the surgery? What was the maximum age of a patient you did the surgery? Thank you.
Well, I can't remember exactly, but the lady that I showed you at the beginning, this is with squamous, this one with squamous cell carcinoma, she was 70 something, 74 or something like that, and then she was admitted with actually she was admitted with bleeding because she was taking some anticoagulants. So so this was the first symptom that we had. And of course, we see more and more elderly patients, but it all depends if they can be anesthetized, yes, because this is the basic problem. And there are more and more patients which are, well, metrically, I mean, they can be 70 something, okay, but biologically they are not that old as you could expect. So of course there is huge diversity, and you can see some opposite situations, but we don't treat the age as a contraindication to this type of surgery.
Thank you very much for your answer. And last question. Last question is, do you have any recommendations or any specific ways to help their postoperative period? So do this patient need some periodic examinations or any specific diagnostic procedures? And what is the time after the surgery they need to do that? Thank you very much.
Okay, of course they are followed quite closely, and we cooperate with institutions that provide irradiation, because in our department we have no possibility of radiotherapy, so we must cooperate with other centers, and basically they are followed by two institutions, but by our department and by these institutions. And we start, of course, with the debridement after the surgery. Then we wait until endoscopically we see that everything is already healed. Then most of them, they are irradiated. Of course, some they don't need it, but it's quite rare. And then we are trying to perform MRI with contrast depending on the tumor, and they are examined in the first year. Well, roughly, I would say every 2 months during the first year. Then we are delaying the next follow-up visits, and then after like 5 years, it's that we see the patients once a year. So gradually we are this follow-up visits are not that often, but they are once a year, and well, basically this is it.
Thank you so much for your answers and for your great presentation. So now we continue with our next reporter, and thank you again. Thank you very much. So we want to give the floor to dear Justinas Vaitkus from Lithuania, and the name of her report is Alterations of Interleukins for Patients with Chronic Rhinosinusitis with Nasal Polyps in Different Age Groups. Thank you. And we're going to show our presentation from our computer. So you just need to comment their slides, and please ask us whenever you want to change the slide. Thank you so much.
Okay, thank you. I just wanted to ask if I have to share, you will share it. So very thank you for opportunity to be able to present my work here in this conference. Before the beginning, I want to know that this is a small part of the doctoral thesis. So this presentation is not going to take way too long. So getting that out of the way, we can start. So my presentation is alteration of interleukin for patients with chronic rhinosinusitis with nasal polyps in different age groups. So for the beginning, as we heard in a very excellent first presentation about chronic rhinosinusitis, it's a heterogeneous multifactorial disease caused by many factors. And that's where the problem arises, because if we have let's talk in this case about chronic rhinosinusitis with nasal polyps. All of you know that we see the patients and the phenotype of the disease, the polyps are present in all of the patients. But when we prescribe the treatment or we do the surgery, we have many different patients that one affected easily by the treatment or have no recurrence after the surgery for 5 or 10 years. And we have other patients that treatment doesn't work at all, actually. And after the surgery, we have a recurrence maybe up to half a year or a year, despite all the treatment we try to apply. So in this place, the idea of endotyping and biomarkers have appeared, and that's where we started our study also. So the idea was that there's a complex inflammatory process taking place in the nasal mucosa, and there's not one type of the inflammatory process. There may be a few types, a different type. Doesn't matter that the phenotype is the same for all the patients. So there was to cover this idea, the study started, and they found that the cytokines may be used to differentiate the endotypes for those disease. But sadly, there is no single validated biomarker, or in other words, a cytokine, that can reliably determine whether a patient has chronic sinusitis or doesn't have it, or chronic sinusitis without nasal polyps, or acute sinusitis, or no disease at all. So that's where we decided to check what kind of cytokines may be important in Lithuanian patient group, because we have a literature that supports that the cytokines and the type of inflammation differs either you're in Europe or in Asia, or even if you live in Germany or Belgium. So the aim was in this presentation, the aim was to determine age-related changes of inflammatory markers, concentration in the polyp tissue of chronic rhinosinusitis with nasal polyp patients, and in the mucosa of the middle turbinate of the control group. So in this study, we enrolled 59 patients with proven chronic rhinosinusitis with nasal polyps who underwent endonasal surgery, and 52 controls who underwent other rhinologic surgeries and had no history of any sinonasal disease or recent trauma. So all patients were divided into 3 age groups. That first group was from 18 to 30 years old, from 31 to 50 years old, and the oldest group was 51 years old and older. So diagnosis of chronic rhinosinusitis was made according to EPOS 2012 because all the patients admitted our department from 2017 to 2019. So the new EPOS was not released yet. All surgeries had taken place in our department, and the tissue biopsies taken during the surgery were taken to laboratory medicine department and frozen at minus 80 degrees of Celsius until the analysis. Nasal biopsies were assessed for levels of interleukins. I'm sorry, there's a mistake. There should be interleukin 1 beta, interleukin 2, 4, 5, 6, 7, 10, 12, 13, 17, 21, and 22. And the Luminex Air Multiplex kit was used in this matter according to manufacturer protocol. Exclusion criteria was patients younger than 18 years old, pregnant women, patient with autoimmune disease, patient with diabetes, patient with chronic lung disease such as cystic fibrosis, chronic obstructive pulmonary disease, patients with Wegener's granulomatosis, and if used, and patients were excluded if they use systemic or topical steroids at least once in the past 2 weeks before the surgery. So in general, for some people to remember, for others to have idea, in this slide, I show the subsets of CD4 cells. So naive CD4 cell is affected by the cytokines, the chemokines, as you see here in the first line is like interleukin 12, and second line is interleukin 4. So these, I'm sorry, these cytokines affect the named CD4 T cell and induces the differentiation of it. So depending on which cytokine affects the naive CD4 T cell, we had a different subsets of the cells that is shown here, like Th1, Th2. It's a T helper cells. You may get T follicular helpers, Treg cells, and all of those subsets differs in that way that they secrete different cytokines also. Like, for example, Th1 secrete the interferon gamma and TNF alpha. If Th2, it secretes the interleukin 4, 5, and 13, and so on, and as you can see here in this slide. Next slide, please. So when we check the statistical significant difference of interleukins in the control group and in the youngest patients group, we got that only interleukin 1, 2, 5, and 22 have a statistical significant difference from the control group. And in this case, it shows that we have mixed inflammation types, because in this case, we see that it's Th2, Th17, Th22, and Treg cells are involved in these patients that are in the youngest age group. Next slide, please. In the middle age group, we noticed that interleukin 2, 4, 5, and 22 have a statistical significant difference from the control group. And according to this, we again have a mixed inflammation type with the Th2, Th17, and Th22 subsets in this matter. And the next slide, please. And for the oldest group, we see that as interleukin 2, 4, and 22, they have a statistically significant difference if compared to the control group. So again, it's a mixed type, but it's similar to the middle age group type. Let's say have a Th2, Th17, and 22. In this slide, we compared all the age group one to each other. And interestingly, we found that the only one statistical significance difference, and that is of interleukin 21, that differs if we compare middle age group with the oldest age group. So next slide, please. For the conclusion, we found that interleukin 2 and 22 levels were significantly higher in chronic rhinosinusitis with nasal polyp patients' tissues compared with tissues obtained from the adults. And I want to remember for everyone that oh my God, you're changing slides, and I forgot to tell some things. If you could get back to the that slide that is the bubble one. with those subtypes I showed. Okay, so for everyone, I want to remember that for sinusitis, they're important ones are Th1, Th2, Th17, and Th22. And Th2 is responsible for activation of mast cells and eosinophils, and stimulates the immunoglobulin E production. The Th17 is responsible for recruitment of neutrophils and response to extracellular bacteria and fungi. And Th22 induces tissue remodeling. And okay, so we can now move to the last slide. And moving forward to the conclusions, so only the concentration of interleukin-21 was higher among the patients with chronic rhinosinusitis with nasal polyps in the 31 and 50 age of group compared with elderly. And interleukin-21 represents the T follicular helper cells that actually in the beginning were thought that they're responsible for the different pathways of Th1 and Th2 inflammation, but recent studies, two studies now that they show that different genetic expression of T follicular helper cells, and now they're moving forward to understanding that maybe T follicular helper cells are it's a way different Treg cells. But to answer all those questions here we have with the age. And as I presented my doctoral thesis, these age groups are a bit too small for the time, and we surely progress with those treatments, with those studies, and hopefully this will help us in a longer time period to find to distinct the patients that will be way easier treated with the medicine and surgery, and predict the possible soon. I'm sorry, I forgot the word. Possible soon recurrence of the disease, and to prescribe every patient the patient-related treatment. This for that patient only. So thank you. Maybe you have a questions.
Thank you so much. It was a very interesting study. Thank you a lot. Yeah, we do have a question. Maybe you can, maybe have an experience. Do you, what tactic of treatment do you apply according to their different groups? If you found that there is a high level of interleukin, like 22 or interleukin-21, does it influence the tactic of treatment in these patients?
Yeah, it should. That's the idea. But because all of those studies are done actually only in laboratory, only for the studies, and we don't do that every day in our everyday practice. So our treatment now is based on the EPOS to 2020. And we hope that in the near future, combining our studies with the other studies that people doing all around the world in the near future, we may be able to more effectively distinct patients with the different subtypes, endotypes, and select. Well, now the trend is biotherapy, so with biological therapy. So, but still, we see that it works for 85%, 90% of the patient, and we still have 10% of the patients that the biological therapy doesn't work at all. And we see that more we know, actually more we don't know. So these studies, they have to be working on in the future, and I hope in the 5, 10, or 15 years it will be very helpful in treatment of chronic rhinosinusitis, and we will be able to treat it without a surgery. Well, in most cases, I hope.
Thank you so much for the answer. Yeah, of course, this is a very interesting topic. Yeah, and the future, of course, it's the future. So thank you one more time. Yeah, and we continue with thank you. We continue with the other reporter, and we are happy to give the floor to dear Konstantin Ustinovich from Belarus, and the name of his report is Non-Pharmacological Sedation of Neonates and Children Before 3 months of age during audiological examination. Please, thank you. Please, dear Konstantin, can you please turn on the audio because we cannot hear you. We see the video perfectly. All you need is just to turn on the microphone. Thank you so much. Yes, it's good now. Thank you.
Okay. So once again to everyone, I'm glad to be here with you today, and I'd like to present our findings on non-pharmacological sedation of neonates and children before 3 months of age during audiological examination. Known that on audiological examination, the child should be absolutely quiet. However, in response to uncomfortable sensations arising, for example, due to the insertion of the earphone cushions, neonates often cry and get restless, which distorts the results of the examination and sometimes makes it impossible to implement. We had to use sedation during audiological examination, and we had begun to seek a safe method of sedation for this category of patients. Drug sedation recommended in such cases has a number of side effects, namely respiratory and cardiac depression. Well known, after feeding, infants usually calm down and fall asleep due to the fact that the breast milk have a sedative effect produced by the inflow of exogenous opiates, and the release of insulin. Exogenous are beta-casomorphins of the breast milk, and they can spread through the blood-brain barrier and influence on opiate receptors of the neonate brains. Increase of insulin level also in peripheral blood also has an analgesic effect. Neonatologists and Belarusian neonatologists too use concentrated solutions of glucose or saccharose to reduce pain in neonates while carrying out painful manipulations. Solutions given to neonates orally produce a pain-killing effect through their action on the opiate system of the brain too. We decided to try such solutions not as a painkiller, but as a sedative for neonates and infants during audiological examination. The objective of our study was to assess the effectiveness of this approach, of the using of concentrated glucose solutions. We have performed the audiological examination of 72 children before 3 months of age using the sedation method with a 25% solution of glucose included in the first study group. 30 children of the same age were examined during the first hour after feeding. It was the second study group. This second group was included to compare the sedative effect of concentrated glucose solution and the breastfeeding. Last, the third group consisted from 24 infants who underwent the audiological examination without the glucose sedation and since more than 1 hour passed after feeding. The child's behavior was assessed by the DEN scale. You can see the scale on this slide. DEN scale is a behavioral scale developed to rate acute pain in term and preterm neonates. This scale scores pain from 0 to 10, where 0 is no pain and 10 is maximum pain. It evaluates 3 items: facial expressions from 0 to 4, limb movements from 0 to 3, and vocal expressions also from 0 to 3 points. For our purposes, for non-pharmacological sedation during audiological examination, we proposed the following protocol. 25% glucose solution. We used glucose powder and boiled or sterile water. Glucose reduces backlash discomfort during audiological examination in infants and neonates up to 3 months of life. In combination with other methods of non-pharmacological sedation, It is only effective if administered orally. It is safe and easy to administer. Our study where otoacoustic emission during hearing screening in newborns and acoustic impedancemetry are virtually inexistent. And how did we use it? 2 minutes before the procedure, the child was given orally 1 or 2 milliliters of 25% glucose solution from a bottle or from a disposable syringe. Introduction was repeated in the process of examination if it was necessary. Okay, results of our study you can see on this scheme. So children from the last group, from the third group, was the most anxiety during examination. For example, when earphone cushions were introduced into the external auditory passage, or when the signal, they responded with very often with episodic or moderate grimace of crying, twitching the head away, with moderate anxiety, and in some cases with periodical short-term crying. Their assessment by Dunn scale was 4 or more points in 83% of cases. The second group, this is the children after lactation. In this group, response to examination was less pronounced compared to the control group. Examination didn't exceed 2 points in 57% of cases. The group of children who received 25% glucose solution before and during the examination was characterized with quiet sleep in 26% of cases. Some of them responded to manipulations with episodic anxiety and a grimace of discomfort. In this group was less than 2 points in 82% of cases. But sedating effect of giving glucose in 5 infants was insufficient for obtaining objective examination results, as you see on this scheme. Kruskal-Wallis test and later post-hoc mini analysis, and they demonstrated statistically significant differences between all these groups of. So conclusions from our work. Taking into consideration the specificity of the concentrated glucose solution on the system of the brain of neonates and infants in peroral application, it can be used not only as a painkiller, as a sedative for this contingent of patients as well. Using the 25% glucose solution is an effective, accessible, safe, and cheap method of sedation while performing the audiological examination of neonates and infants up to 3 months. Examination of newborns should be conducted within the first hour after feeding. In case of anxiety, 1 or 2 milliliters of 25% glucose solution should be administered. The examination shall be repeated in 2 minutes. So, thank you.
Thank you very much for your interesting report. We did receive a couple of questions, so if you don't mind. The first question is, why did you choose this exact percent of solution, like 25% solution of glucose, and this exact dosage, like 1 or 2 milliliters? Thank you.
Thank you very much for the question. Stop sharing my screen. And okay, so why did we use dosages and concentrations? So we used recommendations of Academy of Pediatrics. They recommend to use solutions in concentrations between 24 and 40% of saccharose, and dosage should be from 0.1 to 1 milliliters per kilo. So we used dosages and solutions the same as they recommend.
Thank you for your answer. Another question. So only children before 3 months of age were included in study. Yeah. When did you maybe why only this or range of age from like 0 to 3 months of age in children was used? Thank you.
Yes, thank you very much. You know that the technique of analgesia with concentrated sweet solutions are well pathology, and these solutions well known that they work in newborn children. It's due to specific features of their brain. They have a big amount of opiate receptors and big amount of endogenous opiates in their brain that they can react. And that's why, unfortunately, older children and adults cannot. As when child grow and became older, these solutions became not so effective as analgesics. Not for analgesia, but for sedation. And we found that there is effect even after 1 month of a child's life. And we observed such sedative effects until 3 months of age. And unfortunately, older children didn't have any action on these solutions. That's why it was just empirical observation. We tried these solutions for all the children, but we saw effects for children up to 3 months.
Thank you for your answer. Another question. So, can you please explain shortly how does the glucose solution reacts with the opioid system of the brain? So, what is the principle of this sedative effect? In short words, thank you.
Thank you very much. So it was proven that glucose solutions work through the receptors of the tongue, receptors of the neonate's tongue catch taste and send signal into the central nervous system to endogenous artists. Only newborns have many endogenous opiates in the brain. They opiates endogenous it's birth stress and postnatal adaptation, and also on the newborn. That's why this mechanism can work. So glucose irritate receptors of the tongue, and receptors of the tongue send signal to release endogenous opiates. So this is the way how does it work.
Thank you so much for your answer. It got a lot of got more clear for now, sure. So, and the last question, you said that there are almost no contraindications for this method of sedation. What about maybe the congenital diabetes mellitus might be a contraindication in your mind, like true congenital diabetes mellitus, or is it not the contraindication?
So when we was searching literature data about contraindications for analgesia in newborns, we almost didn't see contraindications. Maybe it was impossibility to use it through the mouth because it works only orally. Another contraindications was when child is already sedated, but we didn't see such contraindications. I think because is very, very small and it works mostly in the oral cavity, and every feeding with the breast milk gives glucose That's why in this exact situation, amount of glucose very even smaller than usual breastfeeding. That's why we didn't see such contraindications in the.
Thank you a lot for your answers. Yeah, thank you for your interesting presentation. And now we proceed to another report. So, and we want to give the floor to the Magdalena Kuzminska from Poland. Report is surgical methods in obstructive sleep apnea syndrome, OSAS. And dear Magdalena, she recorded the presentation and voiced the presentation. So we will just turn on the recorded video file, and then afterwards should be able to answer the questions.
Congress. I would like to introduce you to the broad topic of surgical treatment in obstructive sleep apnea syndrome. Obstructive sleep apnea syndrome is a common chronic disease characterized by repetitive collapse of the airways during sleep. Its estimated prevalence in the adult population ranges between 20 to 25%. It's important to remember that untreated OSAS results in sleep fragmentation, leading to decreased time in deep sleep and excessive daytime somnolence. We can observe also hypoxia and increased sympathetic activation, which results in development of general conditions such as hypertension, heart failure, diabetes, arrhythmias, and so on. The gold diagnostic standard is polysomnography. OSAS presents a therapeutic challenge, and it's best treated in multidisciplinary teams. Patients most often require weight loss. They should avoid sleeping on the back. Some of them need also administration of intraoral appliances or positive airway pressure therapy, which is the most important method of non-surgical treatment. Depending on the severity of the disease, the surgery can be sometimes the treatment of choice or have the role of salvage therapy to improve outcomes in cases of failed or not tolerated CPAP therapy. Surgical treatment may involve the nasal cavity, sometimes with paranasal sinuses and nasopharynx, the soft palate, the oro and laryngopharynx and the larynx, as well as multi-level procedures and hypoglossal nerve stimulation. Among other methods, we should mention transoral robotic surgery, craniofacial and bariatric procedures, and at last, tracheostomy. The first region to influence the respiratory tract is the nasal cavity. We can observe impaired nasal breathing in about 45% of patients with OSAS. Due to inversely proportional relationship between the nasal resistance and the radius of nasal airway, even a slight change in the volume of the nasal cavities causes a significant increase in respiratory resistance. It's worth remembering that nasal airway resistance is responsible for more than 50% of total airway resistance. And with increased respiratory resistance in the nose, the negative pressure occurs in the oral cavity and in the pharynx, causing a collapse of their walls. For that reason, all conditions reducing the space of nasal airways, such as septal deviation, nasal valve stenosis, turbinate or adenoid hypertrophy, or chronic rhinosinusitis, especially with nasal polyps, are the indications for surgical treatment. The procedures are performed typically, septoplasty usually in general anesthesia. In our clinic, we perform it together with turbinoplasty with good results. It's often postulated to avoid nasal packing after nasal surgery in patients with OSAS to reduce the severity of apnea episodes the night after the surgery. Turbinoplasty can be performed classically or with the use of the laser or radio frequency. that makes the procedure easier to be done in the local anesthesia. The same methods can be used while performing adenotomy. The procedure in children, together with tonsillectomy, results in AHI reduction by 51%. Sometimes endoscopic sinus surgery has to be performed in patients with chronic rhinosinusitis, that is itself the risk factor of OSAS. And the benefits from these procedures are similar to the surgeries focused on this septum or the nasal turbinates. The main goals of nasal surgery are an improvement of the respiratory tract, improvement in CPAP therapy tolerance, and in the quality of life. According to many studies, surgery of the nose has no impact on AHI, but normalizes the other sleep parameters such as the lowest saturation, wake-up rate, or apnea and hypopnea time. There is no doubt that this kind of surgery improves CPAP therapy tolerance and compliance, quality of life, and reduces or causes complete resolution of snoring. The results are, however, better in mild OSAS than in moderate or severe disease. The next region of possible surgical treatment is the soft palate. Procedures that are concentrated on the soft palate with exclusion of the tonsils can be considered only in primary snoring and in mild OSAS. The palatine tonsils should be 1 or 2 in size in Friedman scale. That means they should be contained within the pillars or extending to the pillars with low tongue position. Tonsillar pillars should be wide, and the only problem observed should be an elongated uvula and vibration of the soft palate observed in snoring simulation with no visible collapse of the pharyngeal walls. Procedures are performed in local anesthesia and often in outpatient clinic. The basic methods in the surgery of the soft palate is laser-assisted uvulopalatoplasty, resulting in reduction of snoring in up to 67%. Or radiofrequency with high success rates in the first weeks and months after the surgery, but only about 30% of success after 3 years. An interesting procedure is also so-called injection snoroplasty, with an injection of a sclerosant agent into the uvula and on both sides of it. Unfortunately, we seldom have such patients. On the contrary, oropharyngeal surgery procedures are the most commonly performed and most important in OSAS treatment. The basic one is uvulopalatopharyngoplasty that was introduced by Fujita in the 80s. It, of course, involves tonsillectomy, trimming, and reorientation of tonsillar pillars and excision of the uvula with posterior soft palate. Sometimes, however, the term is used also to describe many different types of procedures, such as listed on the slide. UP3 is indicated when the tonsils are size 3 or 4 in Friedman scale, when the uvula is elongated but the tongue position remains low. The airway collapse can be observed, especially in AP direction. These indications are common for the classic UPPP as well as other procedures, like H. palatopharyngoplasty, with preservation of the uvula, or barbed stitch reposition. If the tonsils are smaller and there is AP collapse, the anterior pharyngoplasty can be performed. In case of dominance of the lateral pattern of the airway collapse, lateral pharyngoplasty or expansion sphincteropharyngoplasty is recommended. Higher tongue position require rather Z palatopharyngoplasty or the Australian modification of UPPP with ablation of the base of the tongue. The reported success of UPPP as a treatment of OSAS ranges between 16 and 83%, depending on the definition of a positive outcome. But usually we use SHIA criteria. That means 50% reduction in the AHI with an absolute AHI value of 20 or less. Lateral pharyngoplasty in cases of lateral collapse seems to bring better results than the UPPP. Now I would like to show you the procedure of UPPP that was performed in our clinic. You can see that the tonsils are size 3 in Friedman scale. At first, the pillars are being injected with a solution of lidocaine and epinephrine. Then the right palatine tonsil is removed in the classic way. You can see behind the tonsil the hypertrophic mucosa of the posterior pillar, as well as the posterior wall of the pharynx, narrowing the space. Here we have removed palatine tonsil, and again the mucosa. Now closing the pillars is being performed with layered stitches, each of them at first grasping the deep muscular layer and then the mucosa. The aim of this step is, of course, stretching the walls of the oropharynx. Now the uvula is being resected. We always remember to resect less amount of mucosa in this posterior part of the uvula than in the anterior aspects. And suturing. Now the analogical steps are carried out on the opposite side. And we can see the end result with stretched walls of the oropharynx. In cases of obturation lower to the oropharynx, surgical treatment still can be considered. And the structures that we can reduce are the base of the tongue, sometimes also lingual tonsils. Classical glossectomy is, however, more and more often being replaced by the use of radiofrequency or ablation. The results of such a treatment are improved saturation and sleep quality, also reduction in apnea, hypopnea episodes, and snoring. If there is any obturation at the level of the larynx, it usually affects the epiglottis. But generally, the laryngeal obturation is rarely isolated. The treatment can be a simple positional therapy, and among the surgical methods, reshaping the epiglottis with a laser or use of robotic surgery. As it was mentioned before, in many patients, there is more than just one side of obstruction. The first description of multilevel obstruction comes from Fujita, who observed that half of his patients undergoing UPPP did not respond well to therapy. He noted combined oro and hypopharyngeal obstruction in more than 50% of his patients. Later studies showed even the higher incidence of multilevel disease, up to 87%. Indinitis Riley described 3 types of airway obstruction in OSAS, with type 1, meaning the obstruction at one level only, and this is the level of oropharynx. Type 2, with many obstructions at the level of oro and laryngopharynx or the larynx, and type 3 with obstruction at, again, one level, but the level of laryngopharynx. We need to remember that most of the patients, in fact, more than 90% of them, belong to the second group. For that reason, surgery in many patients should not be limited only to UPPP. The results of multi-level surgery depend on the procedures. Lynn divided them into 4 groups. First group is UPPP with a second procedure, usually opening hypopharyngeal space. And here, the success rate ranges between 22 to 100%. The second group consists of more invasive procedures in the hypopharynx, like open tongue-based resection, that are often connected with the necessity of performing temporal tracheostomy. But here the success rate is higher and ranges from 44 to 100%. Better results are accomplished by performing craniofacial surgery, often also with UPPP as the first procedure. At last, minimally invasive techniques, and they are connected with, unfortunately, worse success rate, less than 50%. One of the newest methods of surgical treatment of OSAS is selective upper airway stimulation with an implanted hypoglossal nerve stimulator. This management is suitable for patients who cannot use CPAP therapy and usually with AP pattern of obstruction. The method is currently indicated for adults with BMI not greater than 35. Hypoglossal nerve is a motor nerve supplying the muscles of the tongue. So the goal of its stimulation is to include branches of the nerve, innervating muscles that protrude the tongue. These are the medial branches. And on the other hand, we need to exclude lateral branches that innervate muscles retracting the tongue, styloglossus and hyoglossus. To perform this procedure, we need 3 incisions. One of them should be performed on the neck, just below the mandible, to implant stimulation electrode on the medial branch of the hypoglossal nerve. The second incision is on the chest, and it's needed for the sensor electrode implantation. And the last, inferior to the clavicle, to create a pocket for implantable pulse generator. The sensor reacts to changes in air pressure in the airways, recognizes inhalation, and sends a signal to the implant through the pulse generator. The electrical pulse acts on the hypoglossal nerve through the electrodes, and as a result, the patient sticks out the tongue. Before going to sleep, the patients usually activate the electrodes with the remote control, and in the morning after waking up, they just turn the stimulation off. As for the results of such a treatment, according to the research by Compelli, that was a systematic review and meta-analysis including almost 400 patients, AHI reduction by 21 was observed at 12 months. The procedure also resulted in decrease of desaturation and life quality improvement. To sum up, OSAS remains a challenge for both conservative and surgical treatment. But still, surgical, therapeutical success is possible and depends mostly on proper pre-operative evaluation and recognition of the site of obstruction. It will surely result in tailored surgery adapted to the specific patient. Thank you very much for your attention.
Thank you so much for your report. Thank you, dear Magdalena. Yeah, of course, it was extremely interesting. And of course, as we can see, there was a lot of job behind the report. So we did receive a couple of questions. Please, can you, if you're able to answer the questions right now, can you please give us a sign or something? Because dear Magdalena, maybe she is currently unavailable.
No, I am available. Good morning once again.
Good morning. Good morning. We are happy to hear you.
Oh,
Yeah, the report was extremely interesting, and of course, we did receive a couple questions. So, the first question is, yeah, as we can see, the problem, the OSAS problem, of course, it is multi-etiological pathology, multi-etiological disease, and of course, it requires a lot of different diagnostic procedures, and of course, it's a lot of different specialists. They are involved in the process of diagnostics and treatment of this problem. So the question is, how this system, how is it performed in your clinic? So is it a separate department, or do you have like a separate cabinet for these patients? And again, because they require a lot of different devices, a lot of different diagnostic methods supposed to be used. So again, are they concentrated in a separate room, or is it like a huge department, or you send the patient to different specialists within one clinic? How does it work? Thank you. Thank you so much.
Okay, thank you for a very interesting question, and I think important for all of us who deal with such patients. Unfortunately, we don't have a center with many specialists, so we rather refer them to one and another. Luckily, we cooperate with pulmonologists from our hospital, so we have such a cooperation. I can send patients with moderate or severe sleep apnea to the pulmonologist to start the CPAP therapy that is led by these pulmonologists. And of course, they send their patients to evaluation of ENT evaluation, and we also treat those patients. But in fact, now we have two kind of centers of sleep apnea and apnea treatment, one in ENT clinic and the other one in the pulmonology. So that is one field of cooperation. The other diagnostic path with these patients. So we have two rooms with polysomnographs, and we every week we admit several patients for such a diagnostics, and that's all. So we are able to perform many of these polysomnographies in a month, but unfortunately nowadays because of the pandemic situation we limited these possibilities. There are many other questions that occur when we think about proper diagnostics in these patients. For example, where exactly is this site of collapse? So what is this real pattern of collapse that I talked about in this presentation? And it's not so easy. The so-called golden standard, but maybe it's not that everyone agrees on that, is DISE, so drug-induced sleep endoscopy. Unfortunately, we don't perform that. But I'm not much disappointed, because there are different opinions on the fact if this DISE is in fact the results of this examination is proper, because very often, more often than in other examinations, we can see in DISE the collapse of the hypopharynx, and we are not sure if it happens in the sleep, physiological sleep, not in the drug-induced one. So we don't perform DISE. Maybe it's not that we don't do it because of our thoughts after reading publications, but unfortunately more technical reasons and organization. For now we don't use that. what else could I say? About this dietitian care. Everyone that is obese is sent by me to the dietitian, but we don't have one person who has surely experience with that kind of OSAS patients. So, but we hope to create a center with many specialists, and I hope that it will be our future, and it will be better both for us as doctors and for the patients for sure.
Thank you so much for your answer. Yeah, and one more question for you. Are you familiar with the SPAP therapy of OSAS syndrome? So, and do you use this type of therapy in your clinic? And if yes, what are the indications for this kind of therapy? Thank you so much.
Okay, of course, I can briefly talk about the indications. Mostly they involve OSAS syndrome of moderate or severe cases, which means that HAI should be more than 15 per hour. It's the definition of the moderate disease, and severe more than 30. So the patients for both groups should be sent for CPAP therapy. But we as ENTs in Poland don't deal with that, and then don't lead such a therapy. This is the field of pulmonological therapy.
Thank you so much. Thank you. Yeah, and the last question is, what is the maximum age for the patients so they can undergo the surgery of their OSAS syndrome?
In fact, we don't have such an age limit. It always should depend on how physiologically patient behaves. Sometimes we have elderly patients who are very vivid and with no severe general conditions, and they will be candidates even for the surgery. But of course, if we have even younger patients, but with many conditions that would make surgery dangerous, then we would rather choose CPAP therapy. Of course, there are sometimes situations when the patient does not tolerate CPAP and requires surgery. But here, in this difficult situations, every time we should think about the risk and the gain.
Thank you so much. Yeah, and one more question. Hopefully, you're not tired yet. One more question is following: as patients with excessive weight, people with hypertension, what do you recommend for these patients? Maybe you cooperate with the dietologist or with general practitioners to normalize their blood pressure, to normalize the weight of the patients. And is this things included in your treatment? Thank you.
Thank you. As I mentioned before, unfortunately I don't cooperate with a specific dietitian, but of course every obese patient is sent for such a consultation. Unfortunately, if the patient is not motivated enough, the results of such diets are poor, I would say. So of course I don't have much experience, but the patients that I know for a few years, I wouldn't say that their weight changes a lot. Some of them, of course, if they're led properly, underwent a bariatric surgery, and I would say that in some cases it would be the best treatment for them. So I hope, as I said before, I hope that we'll create something like a center, so we will group in one place many specialists, and then we'll
maybe the results will be better. So I would say that in many patients, I would say that bariatric surgery will be the best option for obese patients.
Thank you very much for your very interesting report and your answers. Thank you again. Thank you. And now we continue. We want to give the floor to dear Makarin Kebab Andrei from Belarus, and the topic of his report is nasal valve dysfunction, predicting the functional outcome of surgical treatment. Yeah, please. Thank you.
Okay, hello. I'm just trying to show the screen. Something happened.
You just try to find in the lower right angle of the screen, there is a button. Dear Andrei, if you want, we can open your presentation by ourselves because we have it with us. We can start the presentation, and all you will need to do is just ask us to change the slide. We have such an option, so please feel free to ask us. It's no problem for us.
Okay, excuse me, please.
Yeah, sure, no problem.
Am I online? I don't know what happened.
You are online. You can hear you well. If you want, oh yeah, now we see your screen. Yeah, we see your screen.
Now is it?
Yeah, perfect.
Thank you
Perfect.
very much.
Awesome. Thank you.
Yes. So sorry for the delay and some technical issues. Dear Chairman, dear colleagues, let me introduce you my report on topic nasal valve dysfunction, predicting the functional outcome of surgical treatment. There are many examples in history when something happened, changed our world perception. One more thing Steve Jobs showed us in 2007 changed and boosted our everyday digital environment. Small, even invisible things like COVID in 2020 may alternate our everyday lifestyle and habits and relations between people and nations. To know how to act, we would like to predict the results of our actions. Clinical reasoning or thinking consists in calculating the options for the development of the situation with a particular action of the surgeon. That is why we have to take into account one more thing in rhinosurgery, how the action that we do, changing the anatomical structure, will affect the function and sensations of the patient. In order to predict the results of the surgery in rhinology, we must know where to look for one more thing. There is no single algorithm for performing surgery, but there is a variety of methods for solving one. What methods should we use, how to combine them, in what order to use? Currently, in rhinological practice, there is a tendency towards preservation surgery, a targeted solution of existing problems. Let's consider this approach using nasal valve as an example, the dysfunction of which can lead to significant aerodynamic impairments. The nasal valve regulates turbulence by creating resistance to the inhaled airflow. The presented results of computational aerodynamics before and after surgery show a decrease in resistance after an enlargement of the cross-sectional area in the nasal valve region. This behavior of the airflow can be explained by the Bernoulli principle and Puazel's law. According to Bernoulli principle, liquids or gases are accelerated from a place with high static pressure, large diameter pipes or nostrils, to a place with low static pressure, small diameter pipes or nasal valve area, and have a higher flow rate, dynamic pressure. The cross-sectional area of the nasal valve is 20-60 square millimeters compared to 100-300 square millimeters in the subsequent parts of the nose. Thus, it follows from the Bernoulli equation that the highest airflow velocity in the nose occurs in the area of the nasal valve. The lowest airflow rate occurs in the olfactory region. It follows from the Puozeli's law that even a slight narrowing of the tube radius leads to a noticeable decrease in the flow rate, since the radius of the narrow path through which the liquid passes changes the flow by 4. If the cross-sectional area of the nasal valve is halved, then the flow resistance increases 16 times, and if the pressure difference doesn't change, the volumetric flow rate decreases by 16. Every piece of information is valuable and presents itself a puzzle part. In every case, we try to obtain as much of such parts as we can. So, anamnesis, examination, and further assessment of the results is the first step. If the patient has the nasal obstruction, we need to know the following components: time of the day of the obstruction, constant or intermittent, bilateral, unilateral, or alternating, relation to exercise, nasal discharge, allergies and/or asthma, smell disorders, facial nerve paralysis, previous medications, rhinitis, previous nasal surgery, when is septal or rhinoplasty done, do the patient have OP records, or something like this. Then we may do the external nasal examination. We may look for tip support, tip ptosis, lift the tip to see if obstruction improves, try to find tension or saddle nose, aesthetic assessment and clinical photographs, if there is alar collapse, static or dynamic, during normal or exaggerated inspiration, and we may also do such maneuvers as Cottle's or Bachmann's maneuver. If the patient complains about impaired breathing, we need to have some objective measurement to confirm this. We may obtain them from doing active anterior rhinomanometry. It shows the volume of the air that passes through the cross-sectional area in the period of time. We know the severity of the nasal obstruction, the grade, and the reaction to the topical decongestants. Sorry, is my voice a little bit further than the presentation?
No, your voice is completely, up to time. It's fine completely.
At the time, yes. Thank you. Thank you. Sorry.
Sure.
We need to know if the problem is located in this area. For example, we may use acoustic rhinometry that shows us the cross-sectional area of the anterior part of the nose, more precisely the first 5 centimeters of the nose. We can compare two sides, find the place of obstruction, and find the constricted part. Rhinoresistometry shows us physiology and pathophysiology. It may help us to measure the hydraulic diameter as a suitable value for nasal patency in nasal flow, and lambda as a parameter for degree of turbulence. It also shows us if there is or happens a dynamic component, such as internal nasal valve collapse. We may also, in case of if we do not have rhinoresistometry or acoustic rhinometry, we may use some numbers or parts from the anterior rhinomanometry, or we may use CT scans. Computed fluid dynamics helps us to analyze nasal ventilation modalities and helps us to better understand the origin of nasal obstruction. Correlations between calculated nasal resistances and patient perception are stronger after correction of the nasal cycle. So we need to know if the patient's nasal cycle is good or it's alternated. For this, we use a long-time rhinophlebometry that shows us changes in nasal cycle, because the problem of nasal obstruction may also alter during time. Then to make a right choice, we need to put the puzzle together. We need to make a right choice. A right choice for these patients is the appropriate choice. We analyzed all received information. We have the severity of the nasal obstruction. We know the site of obstruction. We know the relation to other structures. We know the relations to the decongestants. So we may narrow our surgical route by making the choice from different surgical methods, because this is the time when we need to choose the surgical tactics and plan. We may combine all one more things in one to know what we should do, what points we should avoid during the surgery, and what technique to choose, because we may choose from, if we are talking about the nasal valve, we may do it like in open technique rhinoplasty, and we may do it like in minimally invasive surgery, addressing only the caudal part of the upper lateral cartilage. So thank you for your attention.
Okay, thank you very much for your interesting report. We did receive a couple questions. So if you don't mind, the first question is, do you have any exclusion criteria? Like, for example, a deformation from the external nose, yeah? Does it influence the diagnostic methods you use or as a predictors or not? Or maybe have any other exclusion criteria which can influence your diagnostic method?
Thank you very much for your question. Yes, if we are talking about the nasal valve or about internal nasal valve, when we try to choose or make an algorithm how to choose the appropriate surgical tactics, yes, we had an exclusion criteria, not other pathology of the nose, to alternate our results. If there was something from this side that may also alternate the breathing or may do the nasal obstruction worse, that was then exclusion criteria. For example, nasal polyps, it was some acute situations in the nose. It was the deviation of the septum near by the nasal valve. In case of nasal valve and other parts. But if we have an algorithm, so if the tactics or our surgical methods are better analyzed, and when we are choosing for such a patient, we may do several surgeries at a time. So we may do the nasal valve correction, yes, the operation to avoid nasal valve pathology, and septoplasty, and we may correct the polyps and so on. Even the preservation rhinoplasty, or during the preservation rhinoplasty, we may correct the nasal valve. So yes, we may do several surgeries at a time to help the patient by one surgery.
Thank you very much for your answer. Yes, and one more question. How many patients did you treat using this diagnostic method? So, what is the amount of all your patients? Thank you.
Thank you very much for your question. By this diagnostic method, we had more than 600 patients to know if they have nasal obstruction that is connected with nasal valve. We haven't done them all the methods at a time. So it was like an algorithm. If the patient had some complaints, or if the anamnesis and the examination of the ENT doctor suggested that the patient had some pathology of the nasal valve. So we made the more experienced, the more valuable methods such as acoustic rhinometry, rhinoresistometry, and so on and so on. So step by step, the nasal valve was operated in more than 100 patients. So more than 100 patients received all these methods together to diagnose the result of the operation. So the situation before the operation and the result after the operation.
Thank you so much for the answer. And the last question for you. So the question is, please, if you can answer. Yeah, this type of diagnostic method, it is performed only in your clinic, and in future, is it possible to use this method in like regional hospitals? Is there the equipment, the devices, are the devices like too expensive, or they're pretty affordable for regional hospitals? And is it hard to know how to use the devices? So maybe doctors from regional hospitals, they can again come to your clinic and study how to use it, and in future they also will be able to perform this kind of diagnostic procedure in their hospitals. Thank you so much.
Thank you very much for your reasonable question. Yes, I agree that all diagnostic methods that were shown to you, some of them are very expensive. Some of them, like computer fluid dynamics, they need very good computers or very good software. Some of them, like acoustic rhinometry or rhinoresistometry or long-term rhinoflowmetry, they need special equipment to have. So I think our aim or our goal is to simplify the step-by-step diagnose of the problem in the patient, and to help to have the algorithm that is more simple, more precise, and more doctors, including the regional hospitals, may use. So yes, we are trying to correlate the results in the acoustic rhinometry with CT scans, because CT is more available, and to have the criteria for doctors in regional hospitals, in what case they should hyperdiagnose patients, and when they need to send them, I don't know, maybe to us, to have them be examined, I don't know, with more methods, or a little bit tougher.
Thank you so much. Thank you one more time for your extremely interesting report. Yeah, and so we reached the end of the first section, which was called Current Aspects of Clinical Rhinology. So, and the organizers of the Congress, they want to thank all the participants, all the reporters, for extremely interesting, extremely informative, and up-to-time reports. Maybe someone has any words to say. Maybe someone from their moderators, Lekkorov, Tomasz Gottlieb, and Saulis Vaitkus. If you do have any words, any remarks, please, or feel free to speak right now. If not, we will continue with the break. So please, if you do have any remarks, feel free.
Well, no, thank you.
Thank you for presentation. Thank you for presentations. Very interesting job. And next session will be for time.
Yes, thank you very much. Thank you one more time. Yeah, the first part of our conference was pretty intensive. Yeah, we had a lot of, again, very interesting reports, a lot of questions. And for now, we're going to make a little break. Yeah, so during the break, you can stay online because we're going to have a couple of video clips streaming with the sites from our city. Hopefully, you will enjoy our sites. Also, we're going to show a couple of devices we are using currently in our otorhinolaryngology practice. So please, yeah, you can stay online. You can go have a cup of coffee. So you can join. You can come back like 10 minutes before we start. So the first report from the second section will start at 12:20 p.m. So yeah, you can join like a couple minutes before, and we will continue our conference. Thank you one more time. Thank you a lot for your reports. Thank you.
One of the most picturesque cities of Europe, a cultural capital of Belarus, Grodno, was first mentioned in the chronicles in 1128. Grodno is a multicultural, multi-religious city with a friendly and attractive citizens. Cobbled streets, original architecture, and many historical monuments give the city special flavor and appeal. Today, Grodno is a large administrative, industrial, scientific, cultural, and tourist center of Belarus, located at the crossroads of the main routes in close proximity to the border with the European Union. Visa-free regime, which has been operating in the city since October 2016, allows foreign guests from dozens of countries to visit the regional center. Due to this, the city's infrastructure is rapidly developing, making the city more beautiful and comfortable. Grodno is a city with open economy. The sectors of the national economy are closely integrated into international economic relations. Foreign trade relations are carried out with 115 countries of the world. Annual exports of manufactured products exceed $1 billion. On the territory of Grodno, more than 325 business entities from 33 states carry out their activities. Over the past few years, the city has provided progressive development of economic sectors. The basis of the city's economy is an industrial complex. The city specializes in the production of hydrogen fertilizers, food products, furniture, engineering products, tobacco, and hosiery. The greatest contribution to the economy and social life of the city is made by the largest enterprises of the region. The flagship of the regional industry and the city-forming enterprise is Grodno Azot Chemical Factory, being the only producer of hydrogen fertilizers in the Republic. Grodno Tobacco Factory, one of the oldest enterprises in Belarus, accounts for 75% of tobacco production manufactured in the country. The pride of the food industry in the region is Grodno Meat Packing Plant. It is one of the 3 largest full-cycle meat processing enterprises in Belarus. Молочный Мир Dairy Company is one of the flagships of dairy branch of Grodno economy. More than 250,000 tons of milk is processed here per year. Conta Spa Company is the largest manufacturer of hosiery in the country, the leader in its sector of industry on the territory of Eastern Europe. Products of ABC and Azov companies, as well as Typhoon Company, which is part of international group of companies Atlas, are well known far abroad. Favorable conditions and comfortable business climate have been created in Grodno. Every year, more than 250 private companies are registered in the city and about 3,500 are currently operating. The Free Economic Zone Grodno Invest, established in 2002, contributes to the city's economic development. Its territory covers more than 1,000 hectares in the city of Grodno, where about 40 residents from 12 countries work. The most dynamically developing segment of the economy is the service sector. It is presented by 3,700 objects of trade, 450 objects of public catering, and 1,300 objects of consumer services. Grodno is a leader among the regional centers for the development of IT sector. In 2016, the only branch of the high-tech park in the Republic was set up in the city. An educational center was created on the basis of the Grodno branch. Its main function is to train personnel staff for IT companies of the country. Intellectual products of Grodno IT specialists are broadly known outside the Republic. Grodno has a high level of education of the city's population and opportunities for rapid training of the required specialists. Training of qualified specialists is carried out by 4 higher educational establishments, 18 colleges and lyceums. Grodno Medical and Agrarian Universities, Jan Pokupala State University of Grodno, which trains specialists of diverse professions with an emphasis on technical specialties, programming, mechanical engineering, industrial and civil construction, are the blacksmiths of personnel staff training for all sectors of the economy. Today, Grodno isn't only a city with great industrial, commercial and economic potential. It is primarily the city of traditions and history. This is the only city in Belarus where the historical center, with its area of more than 300 hectares, has been preserved practically in its authentic look, including a number of cultural historical monuments. Grodno is the only town in Belarus where the 2 medieval castles were preserved. Serious personal staff potential, high-tech enterprises, developed social sphere, tourism industry, and of course, the devotion and love of its citizens. All these undoubtedly foreshadows our regional center of further development and prosperity. One of the most picturesque cities of Europe, a cultural capital of Belarus, Grodno, was first mentioned in the chronicles in 1128. Grodno is a multicultural, multi-religious city with a friendly and attractive citizens. Cobbled streets, original architecture, and many historical monuments give the city special flavor and appeal. Today, Grodno is a large administrative, industrial, scientific, cultural, and tourist center of Belarus, located at the crossroads of the main routes in close proximity to the border with the European Union. A visa-free regime, which has been operating in the city since October 2016, allows foreign guests from dozens of countries to visit the regional center. Due to this, the city's infrastructure is rapidly developing, making the city more beautiful and comfortable. Grodno is a city with open economy. the sectors of the national economy are closely integrated into international economic relations. Foreign trade relations are carried out with 115 countries of the world. Annual exports of manufactured products exceed $1 billion. On the territory of Grodno, more than 325 business entities from 33 states carry out their activities. Over the past few years, the city has provided progressive development of economic sectors. The basis of the city's economy is an industrial complex. The city specializes in the production of hydrogen fertilizers, food products, furniture, engineering products, tobacco, and hosiery. The greatest contribution to the economy and social life of the city is made by the largest enterprises of the region. The flagship of the regional industry and the city-forming enterprise is Grodno Azot Chemical Factory, being the only producer of hydrogen fertilizers in the Republic. Grodno Tobacco Factory, one of the oldest enterprises in Belarus, accounts for 75% of tobacco production manufactured in the country. The pride of the food industry in the region is Grodno Meat Packing Plant. It is one of the 3 largest full-cycle meat processing enterprises in Belarus. Молочный Мир Dairy Company is one of the flagships of dairy branch of Grodno economy. More than 250,000 tons of milk is processed here per year. Conta Spa Company is the largest manufacturer of hosiery in the country, the leader in its sector of industry on the territory of Eastern Europe. Products of ABC and Azov companies, as well as Typhoon Company, which is part of international group of companies Atlas, are well known far abroad. Favorable conditions and comfortable business climate have been created in Grodno. Every year, more than 250 private companies are registered in the city and about 3,500 are currently operating. The Free Economic Zone Grodno Invest, established in 2002, contributes to the city's economic development. Its territory covers more than 1,000 hectares in the city of Grodno, where about 40 residents from 12 countries work. The most dynamically developing segment of the economy is the service sector. It is presented by 3,700 objects of trade, 450 objects of public catering, and 1,300 objects of consumer services. Grodno is a leader among the regional centers for the development of IT sector. In 2016, the only branch of the high-tech park in the Republic was set up in the city. An educational center was created on the basis of the Grodno branch. Its main function is to train personnel staff for IT companies of the country. Intellectual products of Grodno IT specialists are broadly known outside the Republic. Grodno has a high level of education of the city's population and opportunities for rapid training of the required specialists. Training of qualified specialists is carried out by 4 higher educational establishments, 18 colleges and lyceums. Grodno Medical and Agrarian Universities, Jan Pokupala State University of Grodno, which trains specialists of diverse professions with an emphasis on technical specialties, programming, mechanical engineering, industrial and civil construction, are the blacksmiths of personnel staff training for all sectors of the economy. Today, Grodno isn't only a city with great industrial, commercial and economic potential. It is primarily the city of traditions and history. This is the only city in Belarus where the historical center, with its area of more than 300 hectares, has been preserved practically in its authentic look, including a number of cultural historical monuments. Grodno is the only town in Belarus where the 2 medieval castles were preserved. Serious personal staff potential, high-tech enterprises, developed social sphere, tourism industry, and of course, the devotion and love of its citizens. All these undoubtedly foreshadows our regional center of further development and prosperity.
Ja rozumiem, że przerywają, jak jest, ktoś chce dłużej, nie? Czy nikt nie mówi?
Nie.
Ja muszę mieć czasu. Już was słychać, tak?
Hello. Do you see our presentation?
Hello. Yes, we can see your presentation clearly, and we can hear you pretty well. So yeah, this all works fine. Yeah. So.
So of course, we are waiting until 11:20, but I would like to check if everything is okay.
Yeah, everything is okay. Yeah. So yeah, you can be confident. It works just fine. Thank you. Well, and yeah, before we start again,
Professor Niemczyk will show the slides, or you will not be able. Yes, because that's our presentation. So we will be just moving next slides.
Yes. If you don't mind, just do it by yourself. Yeah. Yeah. Thank you. Before we begin, dear colleagues, dear participants of our Congress, again, we're glad to meet you online today. So the first section, was over. It was pretty intense and very informative. So now we're going to begin our second section, which has a name: Major Issues of Otology and Audiology. The moderators of current section are Oleg Kharov from Belarus, Lyudmila Petrova from Belarus, Kazimierz Nemczyk from Poland, and Alina Kuzminina from Lithuania. So we still have a couple minutes. We will wait for our colleagues. Hopefully you had enough time to have a rest, to drink some coffee, maybe eat something, because we have a number of very interesting reports upcoming. Also, we want to remind you that all the poster sections will be available till the end of June on the website of the conference, cgrodno2021.com. Also, you'll be able to download the abstracts, their collection of abstracts from the website approximately in a week after the end of the Congress. Okay, it's like one more minute and we will begin. Thank you for your patience. And thanks a lot for your cooperation. Well, I think everybody has joined, so we are happy to get the floor to our dear Kazimierz Nemczyk from Poland. He has a report which is called Current Indications for Cochlear and Brainstem Implants. Please, thank you so much.
Okay. Dzień dobry. It's my pleasure to present our experiences in this field. As you see here, the next reminding the traditional meeting we began these congresses, and we are here now at the 7th floor of the Banacha Central University, Warsaw University Department, ENT, of course, department, and you can see here some photo from our department. We have now 100 years. It means that this year we are the ceremony of the century of the establishing of our department, and we try to organize this October meeting connected to this anniversary. We will let you know about that because we try to also make the possibility to contact and to be online during the this session meeting. And now I go to my main topic, which is the current indication for cochlear implants and brain stem implants. But at the beginning, I would like to remind you some information, very well known, common, but sometimes it's well to keep in mind at the beginning of the presentation. So what we know from the anatomical study, that the first turn of the cochlea is about 22-23 millimeters. So it means that most of the electrode we insert, in fact, fulfill the basal turn of the cochlea. And of course, you see also that the first turn, when we measure scala vestibuli, scala tympani, has diameters of a little more than 2 millimeters. So we know that the scala tympani is around half of that. So most of the electrode we have in this position, we can fully and easily insert in the cochlea, and the surgical technique is of course well established and developed. But the most hot topic in the last years was how to access the round window and how to insert the electrode. And you see here in this image in the middle on the left, that when we drill out the region of the round window, in fact, the difference between, as you see, number 1, 2, 3 in this image, 3 in green and 2 in blue and 1 in red. So that's the possibility of the place of the insertion of the electrode into the cochlea. So in fact, this very small difference between these 3 sides, but you see that on the image on the right bottom, that the insertion, when you remove the part between the round window membrane and the cochlea, allow to insert directly the electrode into the cochlea. So the discussion of how is the best place to insert the electrode is in the end a little academical, but in terms of the preservation of hearing. So in the meta-analysis study, the percentage of hearing preservation depending on the site of the insertion is the same. But you can imagine that when you insert the electrode just between the so-called the anterior cochleostomy and round window, is much safe in terms of not to disturb the vestibule. So less chances to insert the electrode into the vestibule when you use a little anterior side of the insertion. Of course, it is not very important nowadays because, as I said, the technique is well known nowadays, and no more discussion important in this field are in the literature. Next. So the important issue in the field of brainstem implants is the anatomy of the cochlear nucleus, and you see here that in fact when we implant the electrode, which is in blue in this image on the left, we see then we stimulate dorsal cochlear nucleus and posteroventral cochlear nucleus. And anteroventral cochlear nucleus is out of stimulation. So it means that in this situation, only part of fibers can be stimulated. And you'll see in this image on the right that in fact the main important landmark during the insertion of the electrode for the brainstem implant are the nerve 8 and 9 nerve. But of course, it is a great difference between cochlear implants and brainstem implant, because in cochlear, the insertion is quite easy and safe and repeatable. And in this brainstem implant is completely different, because to find this place, which is well to imagine on the image, but it's quite different intraoperatively. For that reason also, the effects of the brainstem implant is significantly lower than cochlear implants. Let's go forward. So, going toward the indication for cochlear implantation, what are the main issues we are discussed, and there are differences from one to another country. First is the expansion of the audiometric cochlear implant candidacy. Next is the lowering audiological threshold, and more residual hearing are still the indication for the cochlear implantation. The next issue, of course, is bilateral implantation, and in very last decades, last years, but in fact it is the last decade we discussed this topic, is the asymmetric hearing loss and the problem of implantation in unilateral deafness. And besides, there are difficult cases like inner ear malformation, radionecrosis, cochlear implantation, neuropathy, and additional disabilities. In all of these topics, there are a little difference problems we encounter, but one is very important from the surgical point of view is, for example, radionecrosis. Another is, for example, the cholesteatoma of the temporal bone. It is a good indication for cochlear implantation, but the technique we use in this situation is completely different. It means that in such cases, we should make the surgical technique, which we call a petrolateral petrosectomy. So we present some experience from our material. Next, as you see here, there is the statistic from the last years, and I choose some only aspect of this very large series. So the cochlear implantation total number is about 500, and altogether, when we analyze the all years since the beginning, it means since 2001, it's now about 1,000. It means exactly 960 cochlear implantation, including 30 brainstem implants, and 80 patients had bilateral implantation. And now our attitude is that in most of children we tried to go into bilateral implantation, of course, if there is a demand from part of parents. And to compare, you see here the statistic from the British cochlear implant group. As you see that there more a little more percentage of children has bilateral implantation, because in some countries bilateral implantation is routine management. And of course, how to implant the second implant? The best period is about around 3-4 years after first implantation. 4 to 7 years after is a little debatable to implant, and of course after 8 years is not good, not useful procedure to improve hearing. Another issue is electroacoustic stimulation. As you see here now, we have some patients with this type of pathology, and in the experience in many center, most of center, is that in this type of pathology, when we insert the electrode, we use rather long electrode than short, like it was the tendency during some years. So this is our case when we use the commercially straight electrode for normal ears, for normal complete deafness. And next, and as you see here from this slide, that we preserve completely hearing. Of course, we can use the normal technical equipment used for audiological diagnostic for intraoperative monitoring, and this is the case when we use during our operation. Next, and of course we completely patient recover the hearing on the high frequency. Next one. Another issue, of course, as you have seen from this statistic English, that many patients nowadays, old patients in elderly group, can also benefit from cochlear implantation, and still this is also good candidates. Next one. Not only children, which is of course best in this. And what is of great importance, that some of cases can be complicated, not only surgically, but also in the management. And as you see here, the child after several reoperation, it is, of course, I can say that in all situations, we can successfully place the cochlear implant, possibly as a reoperation with no destruction of the implant, or implanting a new one implant after some times of healing process in this region. Next one. So I did not focus many, but sometimes some patients still are not user of the cochlear implants, and as you have seen from our statistic in these previous slides, we have about in this area of about 500 implants, we have 10 of them who are not user. So these patients in the management after, we need to reimplant, remove the implant, and of course still we try to better make the qualification. But of course those patients I am talking about, there are the patients which are in general teenager, or the patient of very, very discutable audiological criteria. And now the problem of NF2, in this type of implantation, the problem is much more complicated. Next one. And of course, it depends of several factors, and we should consider following management possibility. No tumor surgery when, for example, tumor are stable. We can, in this patient, implant the cochlear one. When we remove the tumor and we preserve cochlear nerve, we still have the chance to make the cochlear implantation. But another possibility is very attractive because, but it's still some disadvantages for the patient. But we can consider the removal of the tumor and implant the ABR as a sleeper. And the most frequent situation that then we remove the second tumor and we put the brainstem implant. The most challenging situation is when we reoperate patient after the tumor removal before, and we try to implant the brainstem implant or the reimplantation of the brainstem implant. And so there is still, can you go forward, because I suppose that some slides, so we go back to this conclusion. So you see the statistic descriptive of our patient. Next one, and next. So I would like only to show you the typical appearance of the tumor after one side surgical removal. On the right and the left we have tumor, and this is the most frequent also in our surgery situation when we put the implant, brainstem implant. And next one. So there is still some information about patient here. All our patients were NF2, and when you see here, in some of them we use immediately ABR. In some of them we try to stimulate the cochlear nerve through cochlear implantation. In most of these patients, we should turn into the brainstem implantation. So it is, in our experience, very debatable in the patient as to use the cochlear nerve after removal of the tumor for the successful stimulation by cochlear implants. Next one. And as you see, there are some patients very good in terms of results. Some are not user or a little only with sound detection, now to use sound discrimination to or open sentences. But it depends, and the factors which are the most important is now not still to be well verified or classified to choose the patient for this type of treatment. Mm-hmm. And you should keep in mind also others indication for cochlear implantations and ABR. And as you see here, this is otosclerosis, bilateral transverse fracture, meningitis, different pathology of inner ear. So as you see, this possibility of cochlear implants operation and ABR in some cases can be discussion, and the best choice should be made with, of course, the patient and taking into account the possible result of this treatment. And so we go to the conclusion. So we can go here. So go back. So this is this conclusion is about cochlear implantation. Is not important to back down. So I only say you at in the end the message to take home. So there is enormous progress over the past decades in the development of this type of implantation. CI and ABR centers are responsible for raising general awareness about educating colleagues about new recommendation and indication for C and AB as well in different groups of patients. Further collaborative research is needed to gather evidence to support even more flexible criteria for this operation. And in this way, when we choose beta patient, we can benefit. They can benefit better from our treatment and get better hearing, which is very important for social and another state of quality of life of the patient. So thank you very much for attention, and I am ready to answer your question if any are. Thank you.
Thank you so much for your very interesting presentation. Thank you so much. Yeah, we do have a couple of questions for you. The first question is, maybe you have experience in treatment of patients which have combined hearing loss and tinnitus. What about these patients? How do these implants work with this combination of diseases, hearing loss and tinnitus? Can it help in this case, this device, this cochlear implant? Thank you so much.
Yes, so in general, when the patient has the tinnitus after implantation, they the intensity lower. So for this reason, there is also one of the most important indication for the unilateral cochlear implantation. There is a unilateral deafness with very intensive tinnitus. In this case, really, this indication is very, very good for the patient.
Thank you so much for the answer. Yeah, another question is, so after the implantation of this cochlear implant, there's supposed to be a certain adjustment of the settings of the implants. Yeah, it is a part of the rehabilitation of these patients. So what is the, so how many times, like a month, or what is the period of time when these patients, they have to arrive to your clinic to get their device adjusted properly? So what is the quantity and the periodicity of their visits of these patients? Thank you so much.
So of course, in general, idea is that after 1 month we activate the cochlear implant or brainstem implant, and after that, the patient during the first year, which is the most important, arrive to us at least twice a year. Yeah, but in general, it depends on the patient. But this is the minimum is twice a year. Then in the next years, the frequency can be a little less, so patient can come rarely, but we have in our management all our patients. So after that, the old patient, if I can say like that, arrive to us at least one a year.
Thank you very much for the answer. And the last question for you is the following. So, from your experience, what is the earliest age this cochlear implant can be used at, and what is the maximum age? From your experience, maybe you can give an advice. When is better, to start the treatment? Like from what age, and what is the maximum?
Yes. So the minimum age is not well defined, but we of course we have the patient in the age of 9 months. But this is not the limitation. The limitation is maybe more important is the weight of the patient. So the weight of about 7 kilograms is the lower we have the patient has had during implantation. And when we consider the higher limit, so I think that of course in our material is about 80 years, a little more than 80 years. But of course, if, for example, imagine that there is a 100 patient and he's in good stage and he has he fulfills the criteria audiological and mental and go through this qualification process, I can say that also we would be ready to put the cochlear implants. But in our material, 84 years, it is the most old patient.
Thank you very much for the answers. Yeah, thank you for the great presentation. Thank you for your experience. Yes, thank you so much. And we continue now with the next presentation. Thank you. With the next presentation, and the reporter is Oleg Khorov from Belarus. The topic of his report is smartphones in the diagnosis and treatment of hearing impairment. So please.
Dear colleagues, hearing impairment is not only a medical problem, but also a social one. Hearing loss in children is also a personal problem. The difficulty in obtaining a quality education, the basis of psycho-emotional and speech disorders. Unit now, the identification of the hearing impairment among children of preschool and school age is carried out with the help of speech. In this case, we cannot have any objective data on this child hearing. Methods using audiometers are not feasible due to their higher cost. In 2011, European adopted the consensus in audiological screening for school-age children. The first pilot studies on this kind were carried out in 2006 in Poland. And we decided to show interest in this kind of the research in primary school children. What is screening and its basic principles? Screening programs are based in 10 World Health Organization principles with serve as a basis for recommending and planning screening for the early detection of significant health abnormalities. Hearing loss and its potential consequences certainly meet their criteria to qualify as a health condition that deserves screening. That is 10 principles for screening. We have chosen a screening model based on the tone audiometry. A smartphone is a device that combines cellular functions which they are of the computer. They decided to use the smartphone as a screening device for school-age children. We used to develop a mobile application Petralix as the basis for a screening hearing program for school-age children based on the Android operating system in order to diagnose hearing impairments in a timely manner. This is an application for a smartphone like an analog of the hearing aid based on an application in which for the first time it became possible to use on increased sound supply rate of 44.1 kilohertz. This significantly exceeds the frequencies used in modern hearing aids and increases the bandwidth that is the range of the audible sounds. That is hearing test. To obtain an average hearing threshold calibration is performed during which with hearing threshold of 10 healthy young people, which good hearing are determined for this phone and this type of headphones. The results obtained are average and taken as the average hearing threshold. Hearing tests are performed separately for right and left ear using tonal audiometry at frequency of 125 from 125 to 8,000 Hertz. The test signal is a tone signal of a given frequency with a rising amplitude. Then the user begins to hear a phone, he presses a button. All test results are saved on smartphone and can be sent to an email in the Excel table format. We have completed the following steps: development of a user-friendly interface for examining hearing in children, determination of the frequency range of research, sequence and type of test signal delivery, transmission of the result, its processing and analysis. After successful evaluations of app, we decided to use smartphone with screening software for school-age children. We perform audiological screening in school in Grodno region. We performed otoscopy for all children before screening. Hearing tests were performed separately for right and left ear using tonal audiometry at frequencies of 125 Hertz to 8,000 Hertz. That is picture of a result, normal audiogram, a patient passed test, but that is pathology. Patient did not pass test. Children do not always understand then to fix the head sound in the earphone by pressing the button and continue to listen to the sounds. Girls understand essence of the method much faster and pass the test faster. We have repeat the test more than once sometimes. Not all children in class are tested due to the parents' refusal to carry out this procedure. They examine children. It was total number is 1,267 children. With this from first to fourth graduates of the educational institution. City Grodno, Дятлово, Щучин, and Zelevo. 1,151 children had a normal hearing level. Hearing loss of varying degrees was revealed in 160 children. It is 9.2%. the case of which was exudative otitis media, acute purulent otitis media, chronic otitis media, era pluck, turbotitis, sensorineural hearing loss. Final diagnosis pathology was external ear, externally 69 patients, 59%, middle ear pathology 46 child and 39.6% sensorineural pathology, one child, practically 1%. Total problem we had 9 and 0.2% children. Children who filed the test have never been tested before. The performance of their children was average. Children excluded tinnitus. Parents and doctors of any specialty can use the method without difficulty. That method. Next part. Tinnitus is social problem. Up to 15% of human population suffers from tinnitus. Tinnitus significantly reduces the quality of life in 1% of the population. Tinnitus is a complex, multidisciplinary problem. Dispute numerous studies. There is not generally accepted algorithm for the diagnosis and treatment of tinnitus. Our next development is a mobile application for patients with tinnitus. This will be available to all patients. It is made on the basis of ear noise masking. We took as a basis the principle of treatment of tinnitus according to the model developed by Jastribov, called TRT training, tinnitus retraining therapy. We have added visual stimulation to your mobile app. Our mobile app included a questionnaire, THI, consisting 25 questions with a sense of results, tone audiometry, eye conduction from 155 Hz to 12,000 Hz, psychoacoustic noise metering, audiomatic selection of sound and noise, visual stimulation. The complex visual stimulation enhances the effect of acoustic stimulation. Noise that bothers the patient will also lose its relevance. We have applied this technology 20 patients of the Grodno University Clinic. Inclusion criteria: patients with diagnosed tinnitus and varying degrees of hearing loss, normal or severe, which various comorbidities. The duration of tinnitus is more than 3 months. And exclusion criteria: patient who scored less than 16 points in the THI questionnaire. Patient excluded this patient lasting less than 3 months. Tinnitus severity scale according to THI questionnaire. The questionnaire consists in 25 questions. We have translated in Russian and adapted to Belarusian realities. The THI questionnaire was used subjectively assess the severity of tinnitus in patients. All patients scored 18 points or higher in the THI questionnaire. Result after 2 weeks of using the tinnitus mobile app. Decreased tinnitus, 15 patients 75%. Disappearance of tinnitus, 3 patients, 15%. No change, 2 patients, 10%. Increased tinnitus, no, not. Conclusion. Our mobile application, tinnitus, on a smartphone, the necessary resources of diagnose and treat subjectively tinnitus. The developed application for a smartphone makes it possible to perform a screening examination of the auditory analyzer in order to timely detect hearing impairments in the school and preschool children. A smartphone and required mobile application eliminate the need for expensive equipment, highly qualified medical personnel to perform some therapeutic and diagnostic audiological procedures, for example, hearing screening and or tinnitus treatment. Thank you for your attention.
Thank you very much for your interesting report. Thank you. And now we proceed to the next reporter, and it is dear Ingrida Uloza from Lithuania. The topic of her report is visual dependence and subjective visual vertical in patients with multiple sclerosis. Please. Yeah, we have a recorded version of their presentation. So in the end, you can be free to ask any questions.
Dear colleagues, good morning or good afternoon, depends on the time you are watching this presentation. Thank you very much for inviting me to the event and for the possibility to speak to you. As you see from the group of the authors, we are here ENT people, neurologist, statistician, and 3 gentlemen from Kaunas Technological University. What unifies us is our interest in subjective visual vertical, in multiple sclerosis, and in innovative way to evaluate visual dependence. So multiple sclerosis as a chronic autoimmune inflammatory disease affects central nervous system, and dizziness and balance complaints are those complaints who unifies neurologists and ENT people. And given that multiple sclerosis affects the CNS and considering the widespread vestibular network, it's not surprising that balance dysfunction is a common feature of multiple sclerosis. Earlier, the authors, foreign authors, stated in their papers that static subjective visual vertical test is a sensitive sign of vestibular dysfunction, and it reflects damage along otolith pathways. The degree in which an individual relies upon visual cues, as opposed to the vestibular or proprioceptive cues, is termed visual dependency. Although abnormal visual dependency has been documented in other neurological disorders, it is not known whether multiple sclerosis leads to visual dependence and whether such dependence is related to disease progression, clinical disability, or neuroinflammatory burden in the central nervous system. So objective of our study was to evaluate subjective visual vertical and visual dependence using a novel mobile virtual reality-based system for subjective visual vertical assessment. We called it VIRVEST, and evaluate its relationship with expanded disability scale score, multiple sclerosis scores, and clinical findings. So what does it mean? Testing with VIRVEST system. So here you see our colleague in the picture, how the patients look like. And here I have in my hands the device which we have created. And this device is a Samsung Gear virtual reality headset, 2 smart phones, Samsung. So one phone we put in the gear, and this phone will transmit the picture to the patient, which patient will see as through this headset. Another telephone will be used by the tester, by me, by physician. And here we will see the values of static or dynamic or virtual reality, subjective, visual, vertical, and see it in degrees, repetition, and all the quality of the recording. What patient has also, so this is on the patient, like that, and this is in the hands of the patient. So with this simple gamepad, the patient will adjust vertical and fix when he or she thinks this is vertical. So in this way, I tried to show you a little bit the device. And you see we have no wires. All what you have to do is to charge your phones and have software which is in the distance server, and all these devices together work along through Bluetooth connection. So in a while, I'll try to show you a few seconds of movie where you will see how the stimulus looks for static, subjective, visual, vertical, dynamic, when nice colorful bubbles are turning clockwise or counterclockwise, and the picture of the boat, ancient boat in the sea, floating on huge waves, and the patient will have to adjust the boat vertically. And this is called virtual reality test. So you have seen how the stimulus look like. So this is what we used in our study. So the study included 59 patients with multiple sclerosis and 59 controls. 4 tests were integrated and performed by each patient: static, dynamic, subjective, visual, vertical, with clockwise, counterclockwise background stimulus rotation, and subjective, visual, vertical in a virtual reality background, a boat flowing in the waving water. The boat will be adjusted vertically. Visual dependence was evaluated as a function of dynamic, subjective, visual, vertical. Here, I only want to stress that the system I'm presenting you, I'm showing you, was accredited by the State Accreditation Office for Healthcare Activities under the Ministry of Health of Lithuania as a new medical device in 2018, so it's permitted to use it in the clinical setting, and Lithuanian patent was issued for our group in 1912. And here you see that the server has the information about how to make the test and collects the information from the test. So the physician or tester comes back after testing to the computer, switches to the server, and evaluates all the results in the working place. So consecutive adult multiple sclerosis patients who were referred in the Department of Neurology, Hospital of Lithuania, University of Health Sciences in Lithuania between 2016 and 2018 were enrolled into the study. Of course, they followed written informed consent. The diagnosis of multiple sclerosis was established according to the revised McDonald criteria. All the clinical findings, laboratory data of oligoclonal bands, status, magnetic resonance imaging findings, data of visually evoked potentials were reviewed retrospectively from the medical records. Demographic and clinical data The findings of all paraclinical tests were recorded for all the patients. Disability was evaluated by using Kurske Expanded Disability Status Scale. All patients were assessed clinically at the time of performing the experimental paradigm, and their clinical examination and Expanded Disability Status Scale were recorded. So 59 healthy subjects without complaints of dizziness over the preceding 6 months and with no pathologic, orthopedic, neurological conditions that could cause dizziness, imbalance, or vestibular dysfunction were enrolled into the study as control group. Patients and controls were matched for age and sex. All participants signed informed consent that the study has approval of Biomedical Research Ethics Committee. The clinical neuro-otological assessment for the patients included cervical vestibular myogenic potentials. As you know, this is the test to provide information about inferior vestibular nerve, caloric testing with video anastomography with ear irrigation and 2 temperatures, 44 and 30 degrees of centigrade. And this is for evaluation of vestibular ocular reflex, which corresponds to the function of superior vestibular nerve. All patients were asked to complete the dizziness handicap inventory questionnaire and system usability scale. Healthy controls performed subjective visual vertical and system usability scale evaluation, but no other clinical tests. The main demographic and clinical data of multiple sclerosis patients wouldn't look surprising for you, neurologists. So you see that there were more female. The onset of the age at the onset was quite young. The disease course relapsing remitting was found in 81% of patients, and less were patients with secondary progressive or primary progressive multiple sclerosis. Duration of the symptoms in years, 10 plus minus 7, and symptoms, pyramidal, sensory, visual, bladder, cerebellar, brainstem, mental dysfunction, and dizziness are presented here in the table. The characteristics of dizziness handicap inventory showed that the score of mild handicap, moderate handicap, and severe handicap were nearly equal for multiple sclerosis patients, about 30% for each. The EDSS score less or equal 4.5 was in 66% of cases. The score more than 4.5 was in 34% of cases. Visual evoked potential abnormalities were found in 80%, oligoclonal bands in 91%, pathological CVAMP, pathological amplitude ratio was found in 35%, unilateral weakness according to caloric test in 32%, directional preponderance according to caloric test in 15%. When we calculated the mean values of static subjective visual vertical and all dynamic subjective visual vertical tilts, we found that they were significantly higher for multiple sclerosis patients when compared to the controls. Here in dark gray, you see multiple sclerosis group. In light gray, you see control group, and that was statistically significant. Visual dependence was calculated by subtracting the static subjective visual vertical from the dynamic values of each participant. So mean visual dependence values were statistically significantly larger in multiple sclerosis patients group, indicating elevated levels of visual dependency in the patients group. Multiple sclerosis patients with EDSS score larger than 4.5 demonstrated significantly higher means of dynamic subjective visual vertical and subjective visual vertical in visual reality compared to multiple sclerosis patients with EDSS score less or equal 4.5. So here the results of EDSS score larger than 4.5 are presented in darker gray. Patients with progressive multiple sclerosis disease scores had statistically significantly larger means of dynamic CVV and CVV in vertical reality values when compared to multiple sclerosis patients with relapsing remitting disease scores. And here in dark gray, you see that progressive multiple sclerosis disease scores. System usability scale is a special questionnaire, widely spread questionnaire to assess how the system is perceived by the patients, by the controls. So is it comfortable? Is it easy to use? So, and this score has very high values in both multiple sclerosis group and control group. The largest point that would be achieved is 100. So in patient group, as you see, mean plus minus square deviation, standard deviation is nearly 80 plus minus 13, and in control group, 90 plus minus 12. So, and these results do not differ between patients and control group. That means that the system is really easy and comfortable to use. So what we found making this project, we identified greater visual dependence in patients with multiple sclerosis compared to controls. We found that increased visual dependence in multiple sclerosis is related to increased disability. The real-world subjective visual vertical paradigm is effective in neurological patients, and identifying increased visual dependence in multiple sclerosis opens novel rehabilitation strategies. Thank you very much, and I am looking forward to your questions.
Thank you very much for the report. We have a couple questions for you, if you don't mind. So the first question is, these devices which were used in the treatment, I mean, their three-dimensional glasses and their smartphone, the application, and the remote control, can these devices be used by the patient himself at home, maybe, or if it's necessary, or is it necessary to control the patient while he's using these devices, or he can do it by himself?
Thank you very much for your question. I want to check if you hear my response.
Yes, we hear you well.
Okay. So as you have seen in this short movie, you have seen, this is tympanoplasty. This is not me. Sorry. Can you switch?
Yeah, can you please, can we ask our dear Ludmila to turn off their screen sharing for a second? We will finish with their Karen report, and then you will continue.
Well, so as you have seen in this short movie, there was one part of the screen with the vertical, and the process was going on, and another part of the screen which showed what the physician, the tester, is measuring. So the patient or the person himself, herself, can only play, but no one will take care about the results. So I would say that this is a game for two, not for one.
Yes, thank you so much. And another question is, how often this procedure is needed to be, has to be repeated, like every month or every day, or what is the periodicity of this procedure? How often?
Yeah, well, thank you very much. Indeed, let me remind you that subjective visual vertical is an everyday clinical tool in neurological practice. Most of us learned about it from the courses of Eichelstrup in Munich, where he advised us to use bucket test. Simple bucket, and you measure the vertical. So there are commercially available expensive and large systems to be used, but we decided to make ourselves smaller, less expensive, and easily movable to whatever place you want to work. So if you work in your working place, so you test with this device every patient, because this adds you, ENT working in neuropathology, additional information. Especially dynamic visual vertical is very, very useful. For example, I had today a patient, it was not clear whether it was vestibular neuronitis a month ago or maybe not. So dynamic test was very sensitive and showed deviation of subjective vertical, though static was very normal. So it was one of the things which confirmed that some signs of previously of that vestibular neuronitis, which was a month or more ago, nearly was this disease, and this disease still left some signs. So this is not how often you repeat to test something, but this is everyday tool, like you do video anastomography, like you do balance Fukuda test or tandem walking test, you do subjective vertical as well.
Thank you very much for your answers. Thank you very much for your interesting report. Thank you so much. Yeah, and now we proceed with another reporter, and this is Ludmila Petrova from Belarus, and the topic of her report is biomechanical properties of the fragmented cartilage graft for tympanoplasty. Yeah, you're welcome. So, yeah.
Good afternoon, dear colleagues. Glad to meet you, unfortunately online. I'll talk about the graft for tympanoplasty. As you know, most surgeons use cartilage or fascia to restore the eardrum. This cartilage have positive and negative properties. Positive fascia properties, good acoustic and vibrational ability, easily laid and adapted to the auditory conal walls. Negative fascia properties, tendency to atelectasis. Positive cartilage properties, not prone to lysis and to atelectasis. Negative cartilage properties, more rigid, lower vibrational ability. We use the fragmented cartilage, which have the positive properties of both the grafts. The cartilage plates taken from the tragus and thinned to 0.5 millimeters. Then it's crushed on 0.3 millimeters in the transverse and longitudinal direction using the Cocker forceps, with maintaining the general fragmentary integrity. Then we performed underlying technique tympanoplasty. In order to determine and to compare the effective elasticity modulus of an intact and fragmented cartilage graft, we performed a series of experiments for static tensile on an instant tensile testing machine and some mathematical calculations. It was defined that the fragmented cartilage has the elasticity modulus twice smaller in comparison with the intact cartilage, which indicates a good elasticity and mobility. This facilitates the placement of the graft and its fixation to the wall of ear canal. And this slide demonstrates elasticity modulus of intact cartilage and elasticity modulus of the fragmented cartilage. This picture demonstrates the stretching of cartilage specimens. And as you see, the fragmented cartilage here fragmented cartilage, and here the intact cartilage. And fragmented cartilage has more stretch. An important dynamic characteristics of the restored eardrum is the spectrum of its own resonant frequencies. Mathematical calculations demonstrate the shift resonant frequencies of fragmented cartilage to the zone of low, which corresponds to the resonant frequencies of eardrum. And here you can see spectrum of resonance frequencies. Here is a tympanic membrane. Here is cartilage, thick 0.3 millimeters, and here the intact cartilage, thick 0.3 millimeters. And here you can see comparative characteristic of resonance frequencies. You see that the fragmented cartilage, thick 0.3 millimeters, has vibration frequencies similar to vibration frequencies of tympanic membrane. Fragmented cartilage has another advantage: better supply to nutrients to the capillary effect and activations of aquaporins, proteins regulating the transport of water in the tissue. And this slide demonstrates capillary effect. And we see that intact cartilage after waiting practically does not increase its mass, while fragmented cartilage increases its mass almost twice. We performed the immunohistochemical examination, and this slide demonstrates immunohistochemical features of aquaporins expression. And you see that expression aquaporins 8 is more pronounced in fragmented cartilage. We performed morphometrical analysis, and you can see the results of the expression parameters of aquaporins. Expression parameters of aquaporins such as positivity, intensity index, and total intensity index are significantly higher in fragmented cartilage. This slide demonstrates the results of tympanoplasty. We demonstrate comparative results of tympanoplasty with fragmented cartilage and intact cartilage 6 and 12 months after surgery. In tympanoplasty with fragmented cartilage, perforation was absent in 89% of patients, and in case with intact cartilage in 68%. Here we can see the results of audiological examination after 6 months after surgery. And you can see that in tympanoplasty with fragmented cartilage, air conduction thresholds of 10, 20 dB were determined in 69% of patients, and in case with intact cartilage in 53% of patients. And conclusion. According to its biomechanical properties, the fragmented cartilage graft has several advantages: low elastic modulus testifying to a good elasticity and mobility. The amplitude frequency response is similar to that of tympanic membrane. Thank you for your attention.
Thank you very much for your report. Yeah, and we have a question for you. What about the availability of this cartilage? Is it available always, or a patient has to wait for the cartilage if it's necessary for the surgery? So is it available all the time, or is it like the problem with this?
Thank you for your questions. We use cartilage and fragmented cartilage only when we have a total perforation or subtotal perforation of eardrum. In case with a smaller perforation, we use fascia.
Okay, thank you very much for your interesting report. Thank you. We now will proceed to the next reporter. Yeah, and this is our dear Jacek Sokolowski from Poland. And the topic of his report is chronic otitis media surgery with intraoperative hearing monitoring. So, yeah, please.
Ladies and gentlemen, good afternoon. I'd like to present you intraoperative hearing monitoring problem in chronic otitis media surgery. At the beginning, I'd like to underline that in middle ear surgery, ossiculoplasty is a very important part of this procedure and is still based on the surgeon experience. The assessment of the hearing results is performed by surgeon and patient after completely healing of the operated ear. Hearing results of the tympanoplasties are dependent on many factors, like advancement of the inflammation within middle ear, bone destruction within middle ear, surgical technique, canal wall up, canal wall down, or mixed technique, two-stage surgical procedures, second look tympanoplasty, for example, source of ossiculoplasty, and source of prosthesis material. Hearing results after ossiculoplasty is still an important issue for the otosurgeons. In the past, many authors in many publications described hearing improvement after this procedure. For example, House in 2001 in retrospective study analyzed over 1,000 cases, patients after ossiculoplasty. In over 500 cases, total ossicular replacement prosthesis was performed, and in over 600 cases, partial ossicular replacement prosthesis. In 90%, cartilage was used. In 30%, fascia was used. In 63% cases, average airborne gap closure was below 20 dB, 3 months after surgery. We can notice that in 47% cases, the closure of the airborne gap was over 20 dB. And in conclusions, author described that better hearing results are the first time operated patients, and prosthesis extrusion rate was 4%. In Murphy paper from 2000, in children with partial ossicular replacement prosthesis reconstruction, 30 better hearing results were found than in children with total ossicular replacement reconstruction. In 55% of the operated cases, the hearing remained at the level before the surgery in both groups. The long-term results of the one-step operations were not as good as the two-step operations reported in the literature. Parallel to the clinical, experimental studies were performed. For example, Asai in 1999 analyzed the best location on the stapes footplate for ossicular chain reconstruction. The center side was 3 to 7 dB better than the anterior side above 2000 Hz. There were no differences between the anterior and center sides below 2000 Hz. The posterior side was the worst at all frequencies. Colletti in 1984 analyzed patients that were operated in local anesthesia. The anterior position of the prosthesis shaft provides approximately 10 dB greater improvement across the frequency range than the posterior and middle position. One of the most important questions is what is the reason of the insufficient ossiculoplasty? Offergold in 2010 made a hypothesis that a large airborne gap after ossiculoplasty may be due to a malpositioned or displaced prosthesis. Cone beam tomography is a useful technique to obtain postoperative feedback after ossicular reconstruction and to precisely determine the position of the middle ear implants. RT allows identification of the individual auditory ossicles, identification of the prosthesis, assessment of the prosthesis connection with the eardrum and stapes, and assessment of the angles between the prosthesis and the eardrum, the hammer handle, the stapes plate. Limitations of the combined tomography is radiation exposure from the patient, impaired imaging artifacts, pressure volume effect due to metallic middle ear prosthesis. Cone beam tomography is an alternative to classic CT because high resolution, capacity to identification small structures such as ossicles, relatively low radiation dose, and negligible metallic artifacts. Offergold described that laser Doppler vibrometry measurements in TRP reconstruction showed better results in the prosthesis connected to the hammer handle. LDV measurements in PRP reconstruction showed better results in the prosthesis connected to the tympanic membrane. In the case of PRP, the sound transmission was worse, with increasing the angles between the PRP and the stapes superstructure. What method you can use during hearing monitoring during tympanoplasty? In first group, there are electrophysiological methods, auditory brainstem responses, round window electrocochleography, and auditory steady-state responses. Another possibility is laser Doppler vibrometry. Intraoperative measurements requires the acoustic stimulus, which causes vibration of the tympanic membrane and a reconstructed conductive system. In the electrophysiological measurements, electrical responses are obtained via an electrode placed in the right place. Crucial conditions during monitoring are two working tunnels, external ear canal for acoustic stimulation and posterior tympanotomy for reconstruction of the ossicles and for electrode and measurements, laser Doppler vibrometry. Healed tympanic membrane. Tympanic cavity free from recurrence of cholesteatoma, adhesions, swelling, inflammation. Blood-free tympanic cavity. Blood in tympanic cavity cause underestimated results. And silence in the operating room. It's very important condition. What can we say about ABR? ABR are known as the far-field potentials. Therefore, this technique is quite sensitive to various factors. The electric field of the operating room generates noises affecting the responses. General anesthesia of the patient and his body temperature, significant bleeding during surgery, irrigation of the operating field with the salt solution, high-speed drills used in the middle ear surgery. The technique of intraoperative measurements of ABR is minimally invasive, but is time-consuming. The measurements are 20 minutes long. Round window, ECOG, is known as a local field potential around the cochlea, the technique based on the measurements next to round window. A characteristic feature is a relatively low sensitivity to artifacts from the operating room. Fewer averages compared to the ABR, which results in a shortened measurement time. Obtained intraoperative results significantly facilitate the fast analysis of the ossiculoplasty effectiveness. Auditory steady-state responses is an electrophysiologic response to auditory stimuli. The goal of ASSR is to create an estimated audiogram. Frequencies 500, 1000, 2000, 4000 Hz are commonly used as ASSR carrier stimuli. ASSR can be obtained by using modulation rate of 70 Hz or greater. The attractiveness ASSR for clinical applications results from the possibility to be recorded simultaneously for multiple frequencies to one or both ears. The use of this method significantly speeds up the time of the measurement. Laser Doppler vibrometry is a non-contact technique for measuring surface mobility. The laser beam is aimed at the measuring point and after reflection goes to the photodetector. Photodetectors are devices which convert light intensity into an electrical signal. Next, acquiring signal processing is performed and the results are visualized on the computer screen as a graph of the velocity in the frequency domain. LDV enables ossicular chain or prosthesis vibration analysis, threshold of sound intensity. At the picture we see measurement of the ossicular chain. Inside ear canal is inserted earphone. Here we have a laser Doppler vibrometer. This is the head of this device. Laser beam, staples. Here this is the place for the posterior tympanotomy. In this movie, we see a long columella. Surgeon made the shape of long columella, measuring of the long columella, and then this prosthesis is placed between footplate of the stapes and tympanic membrane. Here is a posterior tympanotomy, electrode for electrocochleography is placed at the nearest of the round window and stabilized by spong. On the surface of the ossicular is placed reflecting foil and the laser is aimed here. In this frame, we see audiogram. This curve, this is bone curve, this is air curve from a pre-operative performed pure tone audiometry. And during measurement, ECOG measured the threshold of the hearing, and we see that this line changes the position and goes at the nearest of bone curve. Here, in this place, we see the laser Doppler response. In conclusions, I'd like to say that round window ECOG and LDV showed its usefulness as a good tool for intraoperative evaluation of the ossicular reconstruction efficacy. Round window ECOG and LDV allow the assessment of the AB-G closure during tympanoplasty. LDV measurements can help differentiate airborne gaps produced by ossicular chain prosthesis misdisplacement in relation to the tympanic membrane from those associated with ossicular chain prosthesis misplacement in relation to the stapes. Such a strategy of simultaneous ECOG and LDV enables shortening of the intraoperative monitoring of hearing, improving hearing, and provides new knowledge about the post-ossiculoplasty mechanics of the middle ear. Further research is necessary to evaluate the usefulness of the method in single-stage tympanoplasty. Thank you for the attention.
Thank you very much for your report. And we have a question for you. So the question is, did you perform a classic audiometry post-operatively? If yes, so after what time do you perform the audiometry, and do the results differ from the intraoperative hearing examination? Thank you so much.
Thank you for the question. We perform, normally in tympanoplasty, we perform pure tone audiometry after healing of the ear, so 1 month after tympanoplasty. When we use this method, we perform 1 day after tympanoplasty pure tone audiometry, and the results of the audiometry thresholds and monitoring thresholds were similar. But unfortunately, after 1 month and after 3 months, these results were a little bit worse. The problem is that with healing, because the healing can change position of the prosthesis. Yes.
Thank you. Thank you very much for your answer. Thank you very much for your interesting report. Thank you so much. And we proceed to the next reporter. And this is dear Alina Kuzminiana from Lithuania. The topic of her report is, does the hearing loss affect the balance function in children? So we do have the presentation. We will start the presentation by ourselves. And dear Alina will just comment the slides. So whenever you want to change the slide, please just ask us and we will do this. Thank you.
Hello, everyone. I'm resident doctor from Kaunas Clinics, and Lina is my supervisor. Today's topic is, does the hearing loss affect the balance function in children? Next slide, please. Childhood hearing impairment is a common condition that may significantly impact speech, social, and physical development. Based on literature data, 80% of children with sensorineural hearing loss and middle ear effusion may suffer from balance control deficit. In children's life, balance control is necessary for many daily activities. Unfortunately, undetermined balance impairment can lead to clumsiness in coordination and frequent falls. If vestibular back. If vestibular system damaged, children may experience difficulties such as cycling, jumping, or catching the ball. Decreased ability to participate fully in normal activities and games with other children can lead to social isolation and affect negatively their life quality. Despite the fact that vestibular impairment can lead to balance deficit and disturb normal motor development, vestibular evaluation is not routinely performed in the pediatric population. Next. Studies have shown that to evaluate the balance function in children with sensorineural hearing loss or middle ear fusion in clinical practice can be used static and dynamic tasks. A similar set of these tasks is a BOTI test. Test consists of nine balance-related tasks, which perform with closed and open eyes. The main advantage of this balance test is that it does not take much time or does not require special equipment to perform it. This test has become a widely used standardized tool in many countries around the world to identify children with motor skills development disorders. The aim of the study is to evaluate the balance function with BOTI test in children with sensorineural hearing loss and middle ear fusion and compare it with normal hearing controls. Research participants were recruited from the ENT department of Kaunas clinics. First of all, the factors that may affect children's balance control were found out. Children were not included in the study with the disorders of the central nervous system, vision, motor function, orthopedic system, or with any other disorder that may affect the balance function. On the second stage, a hearing evaluation was performed. After that, all participants underwent BOTI test, and finally, statistical analysis were made. During the test, children done the tasks like standing with feet apart on the line with open and closed eyes, walking forward on the line, standing on one leg on a line with open and closed eyes, walking forward heel to toe on a line, standing on one leg on a balance beam with closed and opened eyes, standing heel to toe on a balance beam. And in total, 93 patients participated in the study. 31 patients with sensorineural hearing loss, 32 patients with middle ear fusion, and 30 healthy children with normal hearing. The youngest patient was 4 years old and the oldest one 15 years old. The study groups were homogeneous by age and sex. Children with sensorineural hearing loss showed significantly poorer balance abilities than children without hearing disorders in static and dynamic tasks, like standing on one leg on a line with open and closed eyes, standing on one leg on a balance beam with open and closed eyes, and walking forward on a line. The difference was not found in the task where participants were standing on both legs. Children with middle area fusion showed significantly poorer balance abilities than normal hearing children in tasks like standing on one leg on a line with closed and open eyes, standing on one leg on a balance beam with closed and open eyes, and walking forward heel to toe. The difference was not found in the task where participants were standing on both legs. Comparing the sensorineural hearing loss and middle ear fusion groups, the statistically significant results were not found. The study results shows that children with sensorineural hearing loss and middle ear effusion have struggles during the test with closed and open eyes, but the balance deficit is more expressed when the eyes are closed. To detect vision system impact for balance control, we compare tasks result between open and closed eyes. For example, during one leg standing task on a line, healthy children stood 1.6 seconds shorter with eyes closed than with eyes open. Children with sensorineural hearing loss performed the same task with closed eyes 4.16 shorter seconds than with open eyes. The difference was statistically significant between the groups. And the similar results were observed in children with the middle ear effusion group during the both tasks. Comparing the sensorineural hearing loss and middle ear effusion groups, the statistically significant results were not found. For better imagine how vision system affects balance control, I would like to show some videos. In the first one, this patient is with normal hearing control, and he's standing on one leg on a line with eyes opened. The second one is children with sensorineural hearing loss, and he's standing on a line with eyes opened too. It's the same tasks, but eyes closed, and this is normal hearing control. And this is children with sensorineural hearing loss with eyes closed. Therefore, when the compensatory mechanism of the visual system stops functioning, the balance control of children with sensorineural hearing loss and middle ear effusion is significantly impaired, and this is one of the main signs for assessing the balance function in this population. Children with sensorineural hearing loss and middle ear effusion show significantly poorer balance abilities than control group. One leg standing tasks with eyes closed and eyes open are appropriate to identify the balance dysfunction in children with sensorineural hearing loss and middle ear effusion. Balance deficit is more expressed when eyes are closed, and both the test is feasible to detect balance disorders in these children. Thank you.
Thank you so much for your report. It was very interesting. So yeah, and this was the final report of the first day of our Congress. So the organizers want to thank every single participant and all the listeners for their reports, for sharing their experience. We knew a lot of new things, and we got motivated a lot to progress and to study more. So, and now we want to give the floor to Kazimierz Niemczyk from Poland to make some conclusions and maybe remarks about the first day of our Congress. So please.
Okay. Professor Niemczyk is not here. Jacek Sokolowski is here. So I think it was a very interesting session, and every presentation show us a new view on the problem of hearing loss and balance problems, and so very good session, I think. Thank you.
Thank you very much. Thank you a lot. Yeah, we enjoyed the first day for sure. There were a lot of extremely useful reports. So yeah, the day was pretty intense. Yeah, a lot of reports, a lot of questions, great reporters. So we just want to remind you one more time that the poster sections will be available till the end of June on our website, cgrodno.pl. 2021.com. And also, in a week after the Congress, all their abstracts will be available for downloading. So, also, to receive a certificate, you will need to pass a short little test on the website, and then you will get a certificate straight to your email. So, we thank you one more time. Tomorrow, our session starts at 10 o'clock. According to our local time, it's GMT +3. Well, you can join the conference like 30 minutes before. So we would be very glad to hear you tomorrow as well. And we are done for today. So thank you, everybody, one more time. It was a great day. So we wish you good luck and see you tomorrow. See you tomorrow. So bye-bye, everybody. Bye-bye. See you tomorrow. Юрий, а вы слышите меня?
Да, я выключил стрим, пока не ушел.
Что скажете, ваше персональное мнение? Как я сегодня? Ничего?
Да, нормально.
Нормально все?
Только единственный момент, хороший английский, только слово также also читается, на твердое о, там не
Окей, да,
also.
да. Окей,
Остальное
все.
отлично.
Все, спасибо большое вам, это было для меня важно, спасибо.
Спасибо.
Все, спасибо.